We will start. Good morning. We will start in a few minutes. Honorable members.
Morning, Chairperson.
Morning.
Good morning, Chairperson.
Recording in progress.
Good morning once again, honorable members. Welcome to everyone to this meeting, which is the meeting of the Portfolio Committee on Health on the 13th of October 2023. This meeting is called to receive a briefing by the Department of Health on its Q1 to Q4 performance summary, and also briefing by the Department of Health on its annual report. I also want to welcome the Minister of Health, Dr. Patla, the Deputy Minister, Dr. Sibongo Dlomo, the DG, Dr. Buthelezi, Sandile Buthelezi, all our health officials of the Department of Health, all of our staff, all other people who joined our meeting. You are all very welcome. I'm going to first receive an indication of attendance and apologies from Ms. Majalamba, and then I will read the rules of this meeting and then allow the Minister to introduce himself, the Deputy Minister, the team, and then we will go on, honorable members, to receive the presentation. Ms. Majalamba.
Good morning. Thank you.
We cannot hear you, Ms. Majalamba.
Hello, Chair. Can you hear me now?
That's better. Yes, that's
Okay.
better.
Okay. Present is Dr. Jacobs, Ms. Geller, Dr. Harvard, Mr. Faber, Mr.
Ms. Majalamba, is there anyone else who can read that attendance for us? Your voice is breaking up badly.
Ms. Makubane can read the attendance sheet. Thank you.
Thank you, Ms. Makubane.
Morning. In the meeting, we have Dr. Jacobs, Ms. Geller, Dr. Harvard, Mr. Taba, Dr. Notnachel, Ms. Clark, Mrs. Hicklin, Mamuhlengwa, and Mr. Van Staden.
Thank you very much. Honorable members, before I give to the minister, let me just remind you of the rules of this meeting. That this virtual meeting is deemed to be in the precinct of Parliament and therefore constitutes a meeting of the Committee of the National Assembly for official purposes only.
Sorry, Chairperson, I'm present also. Dr. Thembekwayo.
Thank you. In addition to the rules of virtual sittings, the rules of the National Assembly, including the rules of debate, apply. Members enjoy the same powers and privileges that apply in a sitting of the National Assembly. Members should equally note that anything said in the virtual platform is deemed to have been said to the House and may be ruled upon. All members who have logged in shall be considered to be present and are requested to mute the microphones and only unmute when recognized to speak. This is because the microphones are very sensitive and will pick up noise which might disturb the attention of other members. When recognized to speak, please unmute your microphone and connect your video. Members may make use of the icons on the bar at the bottom of the screens, which has an option that allows the member to put up his or her hand to raise points of order. The Secretariat will assist in alerting the chairperson to members requesting to speak. When using the virtual system, members are urged to refrain or desist from unnecessary points of order. Now, honorable members, we do have challenges with the members not switching on their cameras or videos. There's many reasons being forwarded for that, and I am not keen on some of those reasons. Those reasons seem to be always to be connectivity challenges. I think members should find themselves in a position where they would be able to not have those connectivity challenges, and this would include anybody who comes to present to the Portfolio Committee. These meetings are broadcast to the public, and it's not good when there is only a name being reflected and a black background when it is that person's turn to speak. It will also include those who are guests to our meeting. When they speak is to introduce themselves so that those who are watching will be able to know who is the person who is really speaking to them. So I would hope that we will get to improve on this, honorable members, that I'm asking us again, all of us, to ensure we're in a better position to be able to show the people who are following us our faces at least, and introduce ourselves, not the members themselves, but those who are guests on our platform. So having that been said, Honorable Minister, welcome again. We're looking forward to your presentation and the introduction of the team, and we're also looking very forward to the presentations. We will have discussions, so presentations would be until 1100 hours, and then from 11:30 we've booked to 13:30 if it goes that long, for questions, clarity-seeking questions, discussions, responses and discussions. Thank you very much. Over to you, Minister.
Thank you very much, Honorable Chair. I hope my connectivity is good enough. I know you mentioned about the challenge of members and the connectivity. I hope mine is going to last with the camera on, but for now, I'll keep it on. We appreciate this opportunity. Greetings to you and greetings to all the members, honorable members of the Portfolio Committee. We always look forward to this opportunity to present various aspects, and especially this one, which is on the annual report of the National Department of Health. I do have with me the Deputy Minister Jomo, and also the DG, and also other senior members of the management of the National Department of Health. Let me also greet the members of the media who may be in attendance and covering this meeting. We are, as I've said, pleased to present the 2022-23 annual report. And as you have also requested, I've just confirmed with the DG that he will start by a short presentation also on the 4 quarters of the 2022-23 financial year. Chairperson and Honorable Chair and members, even though 2022-23 financial year, which we are presenting here today, transpired mainly under the reduced pressure in terms of the COVID-19 pandemic, it is worth remembering, and I think we should all remember, because it looks like these days we tend to forget very quickly where we have been over the last 3 years. It's worth remembering that we only lifted restrictions in terms of the gatherings, wearing of masks, all the restrictions were only lifted just over a year ago in June 2022, just in the first quarter of the financial year of which we are reporting on. It is also worth remembering that the WHO only lifted the status of COVID-19 as constituting a public health emergency of international concern on the 8th of May this year, 2023, so after the conclusion of this financial year. While the full financial year was executed still under the heavy cloud, hovering cloud of the pandemic, we acknowledge that we are able to start recovery, having a chance to recover, to come back to our full basket of services. As indicated in our vision and mission, as the DG will just quickly remind us what our vision and our mission are. Our core business is really to make sure that South Africans can live a long and healthy life. And in that regard, therefore, our key mandate is the promotion of health. Sometimes we seem to be interpreted as a department of just dealing with the curing of illnesses, and sometimes even reduced to a department of hospitals. But in essence, by right, this is a department of National Department of Health, which must promote health, must prevent disease, and then be able to galvanize the country in terms of prevention of various diseases, the quadruple burden of disease, non-communicable, communicable disease, accidents and injuries. But we must also then be ready for early detection of illness where our citizens do finally fall ill. Detect early and then initiate treatment at the most appropriate level of care and at the best possible quality, and also at the best possible use of resources with the available resources. While the promotion of health and prevention of disease are key in the priorities of the department, we know that we are mainly just in the public, and I must dare to say that even amongst honorable members sometimes, our performance is largely reduced to the treatment of disease once the disease set in. But as I said, our mandate is much broader. And more especially also even the treatment when life is threatened. And that's why you find a lot of focus on the hospitals, even sometimes to the detriment of focus on the primary health care. So we do accept that this is when people desperately need the services. That's when life is actually threatened. So we do acknowledge that, but we also say that we should also remember that it starts even earlier than when life is actually threatened. The DG and the team will provide a much more comprehensive report. I will just highlight on a few issues that with the reduction of COVID, we focused on recovering provision of comprehensive health services from the primary health level, including at community level through our community health workers, to also from the primary level of community and the primary health services, right up to the most advanced specialized and tertiary services. As we moved resources back from dealing with COVID, we had to also refocus on the quadruple burden of disease. Now, in the quadruple burden of disease, we have the communicable diseases. In this case, we have to again refocus on the fight against HIV and AIDS, TB, and sexually transmitted infections. This fight was then rekindled. We came with recovery plans. We have made progress. There's still a lot of ground to be covered. I can mention to you that, as honorable members will know, that South Africa has the biggest antiretroviral program in the world as a most burdened country in terms of HIV. We're currently sitting at just over 5.8 million people who are on ARVs in this country. We however know that the number of people who are known to have tested positive, it's in the region of 7 million. So we still have a gap of just over 1.2 million of people we must reconnect with and encourage them to start on treatment, because as you know, the policy now, it's once a person is positive, then we encourage that they should be on treatment, not wait for deterioration, because we know also that once people are consistently on treatment and the virus is suppressed, we have the slogan which we say U is equals to U, which says undetectable means untransmissible. So this is what we're working on. TB recovery is also remained a challenge. I mean, so TB success in recovery of success in treatment and cure still remains a challenge, because at least with TB we can treat up to cure, and we're still under 80% in terms of success of cure rate. We have approved and even launched, the Deputy President launched our new strategic national strategic plan for HIV, AIDS, and STIs and TB, which was launched on the World TB Day on the 24th of March, just before the end of this financial year. But also, we're not only dealing with the burden of this almost long-term chronic infectious diseases, but also we have had episodes of acute infections like cholera early this year in the Gauteng province. I'm pleased to say to the committee today that the issue of cholera, which is really more than just a health matter, which is also a reflection of the conditions of living in terms of water safety and food safety, that over the last 3 months we haven't had a new case. We can just clarify that we did get to the bottom of what was reported to be a recent case, only to find that it was actually a patient who had presented in May in terms of the cholera. So in as far as cholera and also in as far as measles are concerned, which also was a flare-up late in the course of the financial year, all those acute infectious diseases at the present moment, we don't have any challenge. Non-communicable disease also, of course, is also an explosion of various non-communicable disease, especially cancer. So we're doing everything as well in terms of the promotion of prevention of cancer, and also rolling out in support of provinces to provide support for treatment, oncology services. There are provinces which still don't have those services, like Mpumalanga. I think Limpopo is also still at the bottom low. And so we're working with all those provinces to make sure that we can improve access to cancer treatment. Mother and child health is also key. Every country is judged in terms of how it looks after pregnant women and children. We have made some improvements in terms of the indicators in this regard, in terms of the maternal mortality ratio, and also in terms of infant mortality and under 5 mortality. There has been some improvement, but we can do better in terms of these indicators. Now, the major area also in terms of our burden of disease is a question of injuries. We know that we also suffer a huge burden of injuries from motor vehicle accidents, but also interpersonal violence. Now, during the hard lockdowns under COVID, we had a lot of reprieve, periods of reprieve, when the use of alcohol and other intoxicating substances were at a lower rate. And, we didn't have, for a short period, we had a reprieve. But this is now, with everything opening up, this is now blowing up again. So our casualty departments are really flooded. Motor vehicle accidents, interpersonal violence are filling up, our casualty departments, operating theaters, and ICUs. So this is a social issue. It's a community matter which we need to work with all in society to be able to reduce. So recovery efforts are also hampered, Honorable Chair and members, by financial resources challenge, as you know, as a country, the economy has not been growing, the revenue collection has been reducing, and therefore allocations have been not only stunted, but even reduced. I'm sure in future stages, we will come back to report how this is also impacting on our services. But I'm happy to report to say that, as will be, I'm sure, I know the committee has been dealing also with our entities, but I'm happy to report that as far as accounting for the resources which are allocated to us, we are improving, we are stabilizing, and also improving. From the department itself, as members will know that in the past financial year, we had a challenge after many years of unqualified audit from the Auditor General. We had a challenge in the last financial year, 21-22, with regard to recouping of funds from private administrators, those who are administering vaccines and providing vaccination in the private sector. In terms of recouping those funds, there were disagreements in terms of accounting for that, which resulted in a qualified audit. But I'm happy to say that, as you get from the report from the CFO, that this is now, we have now gone back to an unqualified report. We still have some matters of emphasis, which we also need to deal with, including also on the performance audit, which we are working on to improve. But I'm happy also that also colleagues in the provinces, there's been improvement. Many more provinces have come with unqualified audits. Gauteng, KZN, after many years also of qualified, KZN has come on board with an unqualified report. The Northwest and Mpumalanga, the Western Cape has sustained unqualified report with no findings. The Limpopo report is still pending. We hope that it will come also as a good report. From all the entities of the working under the department, all of those which have reported to you, they've also received either unqualified with no findings or unqualified with some findings. So those still with findings, we hope they will move also to unqualified with no findings. Of course, as the financial year was ending, we had the turbulent periods of the Nehau strike, which disrupted a lot of services. But we are happy to report that subsequent to that, over the last 6 months, there have been very good stability, and we're able to focus again on the improvement of the provision of services to our people. With that, Honorable Chair, can I then ask the DG to come on? He knows the time that we only have until 11 to start with the quarterly report, just a reflection on the quarters, and then go into the annual report itself. With your permission, Chairperson, I invite Dr. Buthelezi to take over to provide the report. I hope that is in order, Honorable Chairperson. Thank you.
That is fine. Thank you, Minister, for that introduction. Dr. Buthelezi.
Thank you very much, Honorable Minister. Good morning to the Honorable Chair of the Committee, the Honorable members of the Committee, the colleagues, and also my Honorable Deputy Minister. As the Minister has put in the preamble to the presentation, I would like to, the way I will do the presentation, I've collapsed the quarter reports. I'll start with them, and then I will go into the actual substantive report for the whole annual report. Introduce myself. As the chair said, my name is Sandile Buthelezi. I'm the Director General of the National Department of Health. So the purpose of this presentation is really to reflect on the achievements and highlights in the annual report for the 22-23 financial year. We will also touch on a summary for the quarterly performance for the department. Our vision as a department is a long and healthy life for all South Africans. And our mission is to improve the health status of South Africans through the prevention of illnesses and the promotion of healthy lifestyles, and to consistently improve the healthcare delivery system by focusing on access, equity, efficiency, quality, and sustainability. Then, of course, underpinned by the NDP 2030, these are the health sector deliverables. Raise life expectancy for South Africans to at least 70 years, progressively improve TB prevention and cure, reduce maternal, infant, and child mortality, significantly reduce prevalence of non-communicable diseases, reduced injury, accidents, and violence by 50% using 2010 as a baseline, completed the health system reforms, established PHC teams to provide care to families and communities, implementation of universal health coverage, filled both with skilled, committed, and competent individuals. We also cross-reference with the different documents that we work on, one being the MTSF, the 2019 to 2024, then our own health sector strategy, and also the pillars of the Presidential Health Summit. This is a standard slide that we use in all our annual reports. So I will move ahead. It's still the same here, just cross-referencing the different documents that guide our planning. And then I'm moving to the first part, where I'm going to deal with the quotas. If we take program 1 in terms of health promotion messages, for quarter 1, we were able to do 116, for quarter 2, 49, for quarter 3, 114, and then cumulatively 399, which is far more above the target of 100 that we had given ourselves. The second one, we would be on program 2, and where we dealt with 2 indicators. One was the portfolio committee meetings and the public hearings on the NHI bill. We attended the portfolio committee meetings and public hearings for the clause-by-clause discussions on the NHI bill, which was then subsequently voted by the National Assembly on the 13th of June, and the NCOP process started immediately after that on the 20th of June. Then on the CCMDD program, which is the Central Chronic Medication Dispensing and Distribution, we had a full target of 5.5 million recipients. For quarter 1, we were at 5,173. Quarter 2 was 5,348. Quarter 3, 5,658. Quarter 4, 6,158, which far surpassed our target. For program 3, on the men's health services, which were to be piloted in a number of facilities, we looked at these are what we did on quarter 1. Men's health services guidelines drafted. Then we did operational research in 27 high volume sites, and then we moved into 25 facilities in KZN, and that was actually achieved. Then actually we went beyond the beyond the target. Then on the NCDs, we implemented the National Strategic Plan for Non-Communicable Diseases in all the 9 provinces, and we showed the target for quarter 1, quarter 2, quarter 3, and quarter 4, where we actually managed to reach all the provinces in quarter 4. In terms of the clients traced by CHWs, we see that for quarter 1, it was 101,344, quarter 2, 287, 279, quarter 3, 345, 344, then cumulatively 451,302, which was above the target that set. We'll touch on that when we do the overall annual report. Then in terms of the assessment of provinces who are in compliance with EMS regulations, we're able, for the first quarter, we only assessed 3. Second quarter, we added 2. By quarter 3, we had already reached all the 9 provinces. Then in terms of the health infrastructure on the PHC facilities that were constructed, in quarter 1, only 2 were done. By quarter 2, we did 9. Quarter 3, only 3. Then quarter 4, which was an overall figure, we're able to do a total for the whole year of 41. In terms of hospitals constructed, only 1 was constructed in quarter 1. There was none in quarter 2. Quarter 3, we had 1. But cumulatively, by quarter 4, we're able to pull together a number. Most provinces, they actually do more work towards the end of the year. So we're able to construct or revitalize 25 hospitals. And then in terms of maintenance, repair and refurbishments, those are the quarterly numbers with the cumulative of 157. In terms of program 6, in terms of boards and councils for quarter 1, we're able to advertise for the Medical Research Council Board. The advert went on until quarter 2. By quarter 3, the board was actually appointed. In quarter 4, we're able to appoint the board of the Office of Health Standards Compliance. And then in terms of the facilities that are implementing the National Quality Improvement Program, in quarter 1, we looked at 34, quarter 2, 134, quarter 3, 215. And those would be PHCs. In terms of hospitals, for quarter 1, 107, quarter 2, 46, quarter 3, 87, quarter 4 of PHCs, which is cumulative, is 1490, and a total of 199 hospitals. Human resources for health implementation. For quarter 1, we demonstrated the module through a user case. The concept note in quarter 2 for financial system data exchange was completed. Then conducting end user training on the human resources information system, change management and data quality improvement. And then the capabilities of the human resource information systems was evaluated and reviewed in the last quarter. And then in terms of the expenditure, the CFO will deal with this one when he comes in to do his part. Then coming now to the actual business of the day-to-day, we will go through the performance information of the 6 programs, and I will move on straight into program 1. The minister has touched on the first indicator that we in the last financial year, we had a mishap of a qualified opinion, but we've been able to turn around. So we have achieved an unqualified audit opinion with some findings. For this year, our target is to move towards a clean audit. Then the policy framework on medical legal claims. This one really we've not achieved, but we are quite advanced in working with the South African Law Reform Commission. We've actually met in the beginning of October. They're about to submit a report that will then assist us to actually craft the relevant legislation that they will recommend as the Law Reform Commission. In terms of the case management system, of course, we've made the system available to all the provinces, but we've not been able to implement throughout except for the Gauteng. There's still issues in the Eastern Cape where they're looking at interoperability with their provincial systems. And Mpumalanga is currently working on data verification. And there's still quite a lot of engagement with Limpopo on this matter to see if we can be able to implement in that area. The next one is touched in the quarterly breakdown. We're able to surpass our target here of 100 messages. We did more than 300. In terms of the minister touched on these indicators. These are the indicators that let us down. These are, if I can say, these are imposed indicators from DPME that are looking at equity. It's a percentage of women at SMS level where We're supposed to have 50%, but we're at 46%. Of course, we do have resignations, people moving, and retirements. It's a moving target, but we are always striving in our recruitment to ensure that we reach this target. Percentage of youth, which is 30%, we are unable to reach this one. We're only able to appoint 13%. As the minister mentioned, it's very difficult if we are not at the call phase because you don't get many young people moving in, except through learnerships, which were once suspended for 2 years. The percentage of people with disabilities appointed, we're really underperformed on this one. This target is 7%. We're only able to appoint 0.4%. But our HR people have advised us that always when they look at the forms that are used to apply in government, which are called Z83 form, some people do not really disclose if they have a disability. So for us then, what are the areas that we need to be working on? We have an audit improvement strategy where we're really targeting a clean audit as a National Department of Health. The case management system, we are still following up with the provinces that are supposed to implement the system. The system is available, it's been demonstrated and been offered through to the provinces. Then on the medical, on the bill, as mentioned, we are pushing that once a Law Reform Commission submits the final recommendation of what legislation we need to put in place, we will then follow the relevant processes as a department. On the equity targets, we will prioritize the targeted recruitment, retention, fast tracking of women into SMS level. We will consult with DPSA, DPME, and the Department of Women, Youth, and People with Disabilities on equity targets for youth and people with disabilities, specifically as we currently have serious issues in terms of the cost containment measures and the recruitment. On program 2, here it's the NHI Fund Purchasing Services by 24-25. The process is still with the National Council of Provinces, and the department has actually currently, but on the reporting period, it was before the NCOP process started. So we've mentioned that we had not done that as the process is really in the parliament. It only started in June, which really not currently our reporting period. Then in terms of the percentage of posts within the NHI, we had targeted 70% of those, and we surpassed that target by 15%. In the package, in terms of moving to a package of CCM of services, in terms of CCMDD, our target was 5.5, and we surpassed the target by more than 658,000 patients. This program is quite popular and it assists us to decongest the facilities. A lot of patients are actually opting to collect medicines closer to their place through the pickup points. Then in terms of facilities reporting stock outs, our target was 3850 health facilities. We surpassed our target by 10 facilities. We've actually had more medicine storage sites that are now willing to report to the National Surveillance Center on the stock outs. Then, as mentioned, the NCOP public hearing started after reporting period, but our team is extremely involved with the NCOP public hearings. Program 3, communicable and non-communicable diseases. First one, 1990, looking at PHC facilities with youth zones. We were targeting 2,000 facilities. We went short by 155 PHC facilities. Here, mainly KwaZulu-Natal, Western Cape, and Northern Cape provinces did not reach their targets. KwaZulu-Natal and Western Cape appointed new program managers who needed to undergo training and subsequently confirming functionality of youth zones. Northern Cape does not have a focal point manager, and there are no partners supporting the program in the Northern Cape. Yeah, Northern Cape, just for information of the honorable members, the PEPFAR that normally supports a lot of HIV programs, they do not support the province of the Northern Cape. They don't have presence, so it's not part. There's none of the 27 priority districts that are in the Northern Cape. That's one of the problems that we have. Then the number of facilities offering HIV self-screening. We're targeting 200 facilities, but we rapidly rolled out to more than 600, surpassing the target by almost 500 facilities. Men's health services were supposed to pilot in 10 facilities, but we moved to 25 facilities because of KwaZulu-Natal actually took the program quite seriously and are moving into more facilities. Then in terms of TB, this is our area, as the minister mentioned, where we really have to work a bit harder. In terms of treatment success rate for drug-susceptible TB, the aim is 85%. The treatment success rate is actually the cure rate plus the completion rate, then that gives you the treatment success rate. But we're only able to reach 77.6%, and we were under by minus 7.4%. The poor performance is really due to adverse outcomes, like the death rate is still on the high side, 71%. Loss to follow-up is at 10%. Then there are still those that are not evaluated, but we also do have the treatment failure, which is 0.7%. Then the number of drug-susceptible TB deaths, we wanted to keep them below 12,381, but we were unable. We had 13,708. So we still have a lot of patients who present very late. Then at that stage, some of them, they come in when it's already very late to save their lives. That's why the death rate is still an issue. Maybe also the issue of stigma here comes in, but we're working hard to teach the communities. Number of people that were started on TB treatment, we're aiming at 221,000. We're unable to reach this target because of our weak community outreach systems for tracing patients and linking them to treatment. And then also non-adherence to TB diagnostic algorithm on expert testing and initiation of treatment. Because ideally, once someone has been tested and test positive, that person must be put on treatment immediately. But there's also an issue of poor data capturing into the electronic system, which we are working very hard with our digital health team to ensure that we improve the data systems for TB. And then on maternal, child and neonatal health, in terms of what we call the side-by-side radio shows, we reached our target and went beyond by having more than 81 episodes. And then a report on cold chain, we did not reach our target here. A lot of facilities need to be assisted on mentorship to complete the report, because we have a new tool that we have introduced to assess the cold chain capacity. So we're rolling it out. So some facilities were still struggling to fill this tool. Then in terms of the schistosomiasis, easily known as bilharzia, this program, we're supposed to implement it in schools to eradicate bilharzia. There's still some work being done. We had consulted WHO and also our expert committee on essential drug listing. So we will actually fast track in this financial year so that we are able to then go into work with education, go into school and offer this program of bilharzia eradication. Then in terms of quarterly review meetings, we're able to do the 4 quarterly review meetings on key child, youth, and school health targets. And the number of quarterly review meetings focusing on performance on women, on women maternal health. Here we did all the quarterly reviews. Then the training of clinicians of sexual and reproductive health modules, focusing on maternal, neonatal, and reproductive health. We were targeting here really to do at least 400 clinicians on different modules. We're able to surpass this target by quite a huge number. Then in terms of COVID vaccination, here in all the age groups, I must say we're not able to reach the targets, even though it was at least closer for those that are older, but for the younger groups, there was really poor demand for vaccination, which is well known. So none of the targets were actually reached on the COVID vaccination. And then in terms of malaria, we targeted 2 sub-districts for 0 malaria cases, and that was achieved. And thanks to the team for that. Then in terms of forensic patients, which is the state president's patients, we aimed to enroll at least 100 new state patients into the facilities. We're able to enroll more than 200. This is because we now have a dedicated manager at head office who actually goes around the provinces to ensure that these patients are moved from correctional centers into the dedicated psychiatric hospitals. The mental health policy framework was approved by the National Health Council as targeted. And then in terms of implementation for the NCDs, all provinces are now having implementation plans for the new National Strategic Plan for non-communicable diseases. Then the updated strategy on the prevention and control of obesity, we're unable to actually get it approved by the to be approved by the National Health Council during the reporting period, but it was approved 2 weeks later and was published. And then a number of hospitals that are compliant with food service policy. We had wanted an additional 100 hospitals, which includes 7 tertiary hospitals, and that should at least have 75% and above in terms of compliance with the policy. We are only able to get 84 hospitals. So that means we're down by 16. Facilities that did not obtain 75% and above on the food service policy assessment had budget challenges and had also infrastructure issues. Hence, they were unable to meet the required 75%. Then with the youth zones, we will continue to assist KwaZulu-Natal, Western Cape, and Northern Cape on this program of youth zones. And then in terms of TB, we need to intensify strategies to promote retention in care, to counteract the adverse outcomes, as well as advocacy, communication, and social mobilization. Then also for people started on TB treatment, we've got a number of interventions, community outreach systems for tracing patients and linking them to treatment. Districts with low expert testing have been identified and will be targeted for training and close monitoring using the QI methodology. We are having deep dive meetings to address data quality issues, working with our digital health team in selected poor performing and high burden districts. Then in terms of cold chain, here we are recruiting additional personnel to support the EPI program for both vaccine coverage monitoring surveillance programs, but also to ensure that the cold chain is actually above board. COVID vaccination, it's a difficult one. We continue to advocate, but the program is now being integrated into routine, and as the minister mentioned earlier on. I did mention that we will be fast tracking the issue of Bilharzia mass track implementation plan. Then hospitals that that got 75% for food service policy compliance, will support them in this financial year. Program 4, we were supposed to evaluate the district health policy framework. This we're able to achieve. Then the audit report on the district health management offices guidelines. Here we were supposed to do only 18 districts, but there was quite wider participation, so we had 20 more districts, more than what were targeted. Then the number of clients that are followed up by community health workers who are HIV and TB clients. Our target was 350,000. We surpassed the target by more than 100,000. Then a number of PHC facilities with ward-based outreach teams. We're targeting 2,700 PHC facilities. We're only able to get 2,630, which is 70 less. Here, there is quite a high turnover of community health workers in favor of formalized paid work. We do have quite young people who enroll as community health workers, but as they get work in administration or in any other places, they do take that work. Hence, there's quite a high turnover in this area. Then in terms of environmental health, the ports of entry compliant with international health regulations were targeted 25 and were able to achieve 25. In terms of district and metro municipalities that are compliant with national environmental health norms and standards. We targeted 26 metropolitan and district municipalities. We actually did 28, which is 2 more. So some additional municipalities did request support from us, and we added them as part of the audit. Then number of provinces that are compliant with emergency medical services regulations, it's all the 9 provinces, so we achieved the target. And then well, this is on the PC on how we're dealing with the trying to address the issue of the engagement model for community health workers. On program 5 year regulations, we target to have regulations relating to the designation and classifications of hospitals that was supposed to be published. This is work in progress. We did discuss it with the heads of departments, but it's taking a bit longer because now, in view of the NHI, we are now also doing the designation of the private hospitals. So it needs some further consultation. So we're unable to finish it in this financial year. Then in terms of a number of user asset management plans assessed for the PHC facilities to be constructed or revitalized, 40 facilities as a target to be constructed or revitalized according to this user asset management plan. We're able to reach a target of 40 and add 1 more facility. And then in terms of 21 hospitals to be constructed or revitalized, we're able to do 25 hospitals, which is an additional 4 hospitals. We had to add some other projects. Then in terms of number of maintenance plans assessed in public health facilities, here we're looking at 120 public health facilities, which includes clinics, nursing colleges, EMS bases that needed to be either maintained, repaired, or refurbished. And we're able to do 157, which is 37 more. We took on more projects here. So as mentioned, we still work in progress on the designation and classification of hospitals, which will now not only be public hospitals, but will include all hospitals, which includes private hospitals in the country. Then in terms of program 6, in terms of the number of boards, we targeted that we'll have to, the minister will need to appoint 2 boards for Medical Research Council and OHSC. This was achieved. And then in terms of biannual governance reports from our entities, all of them were actually produced. Then facilities that are participating in the National Quality Improvement Program, we're looking at 100 PHC facilities and 80 hospitals, but we actually went far more as the provinces duplicated quality learning centers to cover the entire province. So we reached 1390 PHC facilities and 119 hospitals. Then in terms of ideal clinic, our target here was to have 2,200 clinics achieving the ideal clinic status. We were only able to do 2,046. That means we had 154 facilities less. The major issue here is that most of the clinics, because of either attrition of staff or budget constraints, they don't have operational managers in terms of leadership. And that gap is quite critical for us to achieve the ideal clinic status. So this is what we're working on with the process to ensure that at least each clinic must have leadership in terms of the operational manager. In terms of the nursing colleges that were supported to develop training plans for nurse and midwife specialists, all of them were supported in all the provinces. And then in terms of a revised set of health research priorities, we did produce a revised set of research priorities. And then performance dashboards for national, provincial, district levels developed. These were actually developed during the reporting period. Then in terms of community service policy review report, we do have actually a draft policy report, and we will be presenting it to the Tech NHC. But there are also quite a number of things that need to be finalized with the provinces. Here, some provinces feel that community service they can do without, but the rural provinces, they still need a community service. So we're trying to negotiate with the provinces so that we are all aligned in terms of the final policy that we will present to the National Health Council in time, hence when unable to finalize it. Then the human resource information system implementation at both national and provincial offices, this was done. Then in terms of the areas of underperformance, it's the area of appointment of operational managers, which we're checking up with the heads of departments in the provinces. Then we believe we should be able to finalize the community service policy in this current financial year. Then in terms of the targets, we actually have we have 52 targets. We're only able to reach 31 targets. Our very serious problem was in program 1, and here really was mainly those imposed targets by the PME in terms of the equity targets that let us down, as the minister mentioned, with the overall of just less than 60% overall performance. Then in terms of which will be my last slide, in terms of at head office, the human resources, our vacancy rate is actually sitting at just less than 20%, which is 19.8%. Of course, it might worsen with the cost containment measures. We will be losing in year now 205 million as a department. But we do want to fill all the important positions. I think this will be my last slide. Thank you very much. I will hand over to the CFO. CFO, can you please come in with the financial management with the inductions of the chair?
Thanks, DG. Morning to Honorable Chairperson and members of the committee, Minister, Deputy Minister, and all in attendance. I'll go through the finance slides. The chair here, it says the host disabled participant screen for sharing. Can they allow me to share? Or DG, maybe continue to share the presentation.
I think it might be better if DG can continue to share.
No. Is it? Can I continue?
Proceed, CFO.
Yeah. On the presentation on the finances, I'll start with slide number 1. We do indicate the spending of the department for previous financial year. We do indicate the spending in terms of all the programs. As a department, we allocated 64.5 billion and we have spent 62.8 billion, which represent 97.4%. I'll also indicate the reasons as we continue on the presentation. On the next slide, we indicate the spending in terms of economic classification. In terms of compensation of employees, we have spent 93.7%. Goods and services, we have spent 71.6%, but we'll also indicate the reasons of the underspending. In terms of the transfers to the provinces and our entities, we have transferred all the monies. And also in terms of a capital expenditure out of the allocation of 1.4 billion, we have spent 958 million, which represents 66.6%. On the next slide, we indicate the reasons in terms of compensation of employees, where we indicate that the underspending is due to vacant and critical posts, which were in process of being filled, and also that most of SMS level posts were re-advertised a number of times due to poor responses in terms of quality of applications received, and also that we continue to conduct competency assessment and personal suitability checks. Also, as a department, we are embarking on a process of alignment of functions where posts with similar functions are grouped and redefined. In terms of our goods and services, the underspending, we do indicate that there were disputes in terms of invoices for Department of Public Works. So that has resulted in 49 million not being paid. And also in terms of NHI, 41 million was not spent as a result of delay on the recruitment of the posts. And also in the business plan for the NHI, there was an allocation under the indirect grant of 85 million for capitation, which was also not spent. So the limited staff number has resulted in limited capacity of the branch, which is NHI, to fulfill the plans of health technology assessment, which has resulted on 16 million not being spent. We also had an underspending amounting to 712 million under the COVID-19 vaccination program. That was as a result because we had sufficient vaccines on stock. So then as a department, we did not continue to procure additional vaccines. We also did not spend 25 million as the department were in process of finalizing the procurement of measles vaccinations. Under the purchase of the capital assets, we were still finalizing the appointment for a service provider for Limpopo Academic Hospital, which we can indicate that has been appointed, and underspending in previous financial year, it was 397 million. Also, we're in process to procure medical equipment for provinces under chronic disease prevention. That has resulted on 11 million not being spent. Also, we had 40 million unspent due to procurement of IT equipment for medicine stock civilian system and patient information system for provinces that was not finalized by the end of the financial year. As indicated in terms of program 1, the allocation was 786 million. The spending was 645 million. So the underspending here, mainly as I indicated, the issue of the non-payment of the invoices to Department of Public Works with regards to rentals. That was the main reason in terms of program 2, which is our NHI. The underspending in terms of the capitation of 85 million and also the recruitment of posts within the program that has resulted in the underspending of 210. In terms of program 3, communicable and non-communicable diseases, the underspending in this program, it was mainly due to the sufficient vaccines that we had on stock that we did not continue to procure. That has resulted on that 712 million not being spent. In terms of our program 4, which is a primary health care, the spending was within the acceptable norms, which was 99.9%. We also do indicate the sub-programs in terms of each programs I'm presenting. In terms of our program 5, hospital services, the underspending was with regards to health facility infrastructure management, where we did not spend the 387 in terms of Limpopo Central Hospital. Then the last program is the program 6. The program 6, that's where we transfer the money to our entities, and also, as I've indicated earlier, that all transfers were transferred as planned. So the spending within the program was 99.5%. The next slide is the conditional grants. On the conditional grants, from the money that we get, the 57.7 billion, Chairperson, it also does include the rollovers of 1.4 billion, which I will indicate as I proceed. But as a department, we had the 56 million that we transferred to our provinces, including the entities. The spending in terms of the conditional grants was 95.9%. So there were other conditional grants that the spending was not within the norms. Those grants is the health facility revitalization grant, where we spend 89.8%, which is 752.2 million, and also the NHI, where we spend 84.4%, but we will also indicate the reasons as we continue. The amount is 117.4 million, and also the HIV and AIDS, the spending was high on 97.2, but due to the huge or the high allocation of 23.9 billion, so that has resulted on 833 million not being spent. While we have the NTSG, the District Health Program grant, and the statutory training grants, which they have spent within the targeted norms. In the next slide, Chair, we're indicating the grants in terms of the totals. In terms of the grants, as I indicated, the NTSG, which is our first grant, we have spent 95.7%. In terms of the second, which is the District Health Program grant, which it includes HIV and AIDS, and District Health component, we have spent 97.2%. In terms of the Health Facility Revitalization grant, we have spent 89.8%, but we will also indicate in terms of the province's spending, and also the last one in terms of the NHI will also indicate in terms of the provinces. The next slide, we indicate the total spending in terms of all the provinces. The only slide, Chair, maybe just to indicate in terms of Gauteng province, it has spent 88.1%, while you realize all other provinces, they have spent almost 99% or 100%, except Gauteng on 88%, and also except Northern Cape on 93%, and Northwest on 94.3%. In terms of the NTSG, all provinces have spent within the acceptable norm, except the Gauteng and Free State province that underspent due to delays on the delivery of medical equipment. GP province Gauteng has applied for rollovers of 516 million. However, I will indicate that only 259 it will be approved while we're waiting for the final documents from National Treasury. And also just to indicate that Gauteng province have made commitments for procurement of assistive devices and medical equipment, and also including the construction of bunkers. In terms of the District Health Program grant, which it includes the HIV and AIDS, I can just go to the next slide because it also indicates in terms of the two sub-programs. And the overall spending reflects slight underspending, which is mainly of the underspending on the condom supplies, medical male circumcisions, which is known as MMC, and the regional training centers, and also the outstanding NHLS invoices under the TB component. While other provinces that spent within the norm, you'll realize that the Gauteng is underspent with 87.9%. On the statutory HR and the health profession training, so it also has the two components, which is the statutory HR component and also the training component. In terms of the spending for this grant, they spent within the norm. So the provinces have spent as indicated, Chair. The next slide, which is the health facility revitalization grant, which I've indicated that there is an underspending. If we look on Gauteng province, the spending was on 63.4%, while you will realize other provinces, the spending is almost above 90%, except Gauteng and also Northwest sitting on 79.8%, and also the Northern Cape sitting on 81.5%. Some of the reasons of this underspending, the underspending were mainly due to the poor performance of the contractors, and also the termination of professional service providers. However, the province, together with Gauteng Department of Infrastructure Development, they were busy appointing the new PSPs, which in the current day will improve the performance, and also the delays due to business forums in other provinces, and also these provinces, they've requested the rollovers, which I'll indicate as we continue. In terms of the NHI, as I've indicated, the NHI grant is the one that includes the HP contracting oncology, and also the mental health. In terms of the HP contracting in the provinces, or within this component of HP contracting, the health professionals contracted in here, it includes the medical officers, dentists, dental assistants, and also during 2022-2023 financial years. So the greatest number of these health professionals were contracted in Gauteng, while other provinces, they did not manage to contract as expected. However, the provinces, they've achieved more than 85% of their target, while Limpopo continued with their alternate model of contracting healthcare services, where they contract the private hospitals to provide the specific services to the patients to achieve the same goals. In terms of the health, National Health Insurance Grant on the mental health, so this grant, this component on mental health, the healthcare practitioners here includes psychiatrists, psychologists, occupational therapists, social workers, and registered counselors. As I've indicated earlier, most of them, they have been contracted in Gauteng, while other provinces, they suffer. But however, most of the provinces, they have achieved to contract over 70% of the anticipated registered counselors. With regards to oncology, while much progress has been made towards realizing the objectives of this grant, there is still a couple of challenges, a number of appointed processes, a long appointment process, and the difficulty to retain within the stipulated time frames. Some of the challenges attracting professionals to some of the rural areas and into temporary contracts positions, and also retaining professionals with uncertainty, like some of those service providers where there are delays in payment of salaries. So these challenges resulted in fewer healthcare professionals being contracted with, and gaps in the service delivery during the period of contracting the new staff. The next slide, Chairperson, is the slide where we indicate the National Health indirect grants. These are the grants which we're receiving within the National Department. The only two items to indicate within the slide is the underspending under Health Facility Revitalization Grant, where I've indicated that the contractor to start the Limpopo Academic Hospital was not appointed, but then that has been appointed in the current financial year. So that has resulted in the underspending, as we have indicated. And also on the last item with regards to HP contracting capitation, 85 million, there was nothing spent. These are the national indirect grants chain. There's also a program within the National Health, which is funded within the indirect grant, which is the CCMD. Some enabling factors that improve the outcome of service delivery within this program, because it has reduced the demand at hospitals and clinics by taking the recipients out of queues and allowing them to collect their medicines in a range of pickup points outside these facilities. It also allows flexible hours for people on chronic medication to collect their medicines. It does increase the compliance, because they do collect the medicine at their own times. It also allows the healthcare professionals to see patients on chronic medications less frequently, but still to ensure that they are closely monitored so that they all take their medications. Then in terms of the preliminary approved rollovers, as I've indicated, out of all the submissions for the request for rollovers in the current financial year, we do indicate the preliminary approved rollovers. So we do indicate per each conditional grant in the provinces. We also do indicate per each province. So what I will indicate is that the total that we're expecting is 657 million to be approved as part of the rollovers. The last slide, Chair, is with regards to the audits. As the Minister has indicated earlier, as a sector, there is improvements. The first one, in terms of the improvements, we have got the clean audits and unqualified audits in terms of the entities. And also as a national department, we have improved from qualified to unqualified audits. And also just to appreciate the KwaZulu-Natal, after a decade, they have managed to receive an unqualified audit, while we continue to appreciate and congratulate the provinces that have retained the unqualified audits, which includes Gauteng Province, Mpumalanga Province, and also Northwest Province. While we would like to indicate that the outcomes for Limpopo is still pending because AG has not yet finalized the process. While there is other challenges in some of the provinces where we're still working together to ensure that we improve the audit outcomes, which includes our Eastern Cape, where they had the qualification in terms of contingent liabilities, and also our Free State, which also had the qualification in terms of immovable tangible assets, and also Northern Cape, that they had a couple of qualifications, which we will continue to support the provinces to improve the audit. That was the last, Chair. Thanks, DG, Minister, and the Honorable Chair.
DG, anything more from your side?
No, thanks, Minister. Thanks, CFO. That's all from our side, Minister. Thank you.
Thank you very much, Honorable Chairperson, honorable members. That concludes the presentation from our side. We've been able to do that within less than the allocated time of up to 11 o'clock. So we have spared you 15 minutes, 16 minutes. So we are ready to engage on the presentation. Over to you, Honorable Chairperson. Thank you very much.
Thank you very much, Minister, DG, and CFO. Minister, thanks for saving us the 15 minutes. I'm not sure whether we'd be able to save you more time towards the end, but we will see how the day goes. Very important presentation. After we had received these presentations and had discussions with the entities, I am certain that matters which the note from myself, we appreciate the improvement in your in the audit outcome. We are really hoping that going forward there would be an even more improvement towards you receiving a clean audit. We do note that some of the entities have received clean audits, 3 of them, 4 qualified audits with findings. And we also know that a couple of things were raised by the AG, specifically on ICT, your care management system for medical legal claims. And then there were also points raised on the National Digital Health Strategy and the fact that there is no real cyber security system in place, understanding that what we work with is very confidential information of the people of South Africa. I just wanted to give those few introductory points before I'm going to give the members an opportunity to engage with the presentation. And we will then, after that, I will raise a number of issues myself. So right now, I will hand over to the members. The first one is Honorable Gela. Secondly, let me just grab my pen. So it is Gela, Nothnagel, Van Staden, Chirwa, Kaba, Thembekwayo, Clark, Lengwa, Harvard, and then Eklund. So in that order, honorable members are going to be Honorable.
Chairperson, my hand is also up.
I said Clark because yours is named as Michelle. You should maybe change your.
Mine
I'm
also
having
is
a big
up, Chair.
problem, Chair. Sorry, Chair. I'm having a problem with my system today.
But I did pick up, it was you. I picked up your first name, so I did mention Clark.
My hand is also up, Chair.
And then Moroane at the end. So I'm going to repeat. It is Gela, Nothnagel, Van Staden, Chirwa, Kaba, Thembekwayo, Clark, Lengwa, Harvard, Eklund, Moroane, in that order. Thank you, honorable members.
Thank you very much, Chairperson. Let me first welcome the comprehensive presentation done by the Department of Health and under the leadership of Minister Joe Phaahla. Indeed, you have improved, and we are happy that you also have a plan to address all the challenges in your presentations. My observation, Chair, the department has a crucial mandate of delivering accessible quality health care and fast-tracking the implementation of the NHI to achieve universal health coverage for all. Therefore, it is imperative that the department improves its governance and operations to realize its developmental and constitutional obligation. We should applaud the department for obtaining an unqualified audit outcomes in this regard, and we really applaud you. This is an improvement for the quality, for the qualified audit outcomes in the 2021-2022 financial year. It is also commended that the department has made a provision towards the prevention of irregular and fruitless expenditure in the current financial year, noting the room for improvement. Management is also commended for strict improvement the performance of the department, and is urged to continue tracking the findings in the AG's report, as we have received the AG's report on Tuesday. Notable achievement under this period, including achieving 94, 76, and 92 in HIV target, a goal against the 95 target, which all of us we know the 95 target. For these kind of achievements to be maintained and improved, the NDOH must attend to the challenges identified by AG, which I think members, they've also noted that, which include delays in the implementation of the National Digital Health Strategy, which has been a record funding since 2021-2022 financial year, as well as inadequate IT cyber security strategy. Overall, the department has underperformed with a 59.6 achievement of target. 2.3 billion if underspending on the conditional grant. Gauteng underspent by 1.1 billion. Those are my overview and also observation regarding the presentation that is being tabled to us as members today. Coming to my question, Chair, one, noting the level of micro-legal cases, what measures are in place to expedite the legislative process? Secondly, in relation to the 75% claims against the department budget, what financial risk can this cause, and has the AG ascertained the reliability and appropriateness of the claims values? Lastly, what are the reasons for these parities in a blood alcohol test between Pretoria, which has a backlog of 7,370 and 50,441 in Johannesburg, compared to the zero backlog in Durban and Cape Town? Those are my questions, Chair, that I want clarity. But Minister, I must also comment on the support that we get from your office, particularly Mr. Joe Khatla, the good work that he is doing to support us as a committee. He's been with us since we started the term of office until now. Although I understand that there were some challenges, but I think we have addressed. But I must thank you for allowing Mr. Khatla to support us, and also he's so humble, down to earth, which is what South Africans are looking at, and we really appreciate. Even when we go for a public hearing, he's always with us, supporting the department and also supporting honorable members. We really appreciate the support and the good work that the department is doing. Thank you very much, Minister and Dr. Buthelezi, for this report. We are looking forward to implement the NHI. South Africans have said mouthfully that they can't wait longer. And as a parliament, we have already passed the bill. It's now with the NCOP, and we hope that it will be passed this sixth parliament, so that people can get equal access to healthcare, despite whether you are rich or poor, but will get a service that we deserve as South Africans. Thank you very much. Forward with NHI, forward.
Thank you, Chair. And I also would like to say thank you to the presentation and the hard work that's going into that. I've got a few questions that I would like to ask the committee. Why does the department target youth employment focusing on leadership, while many young health professionals such as nurses and doctors in other circumstances are unemployed? My next question, what is the place to close the non-achievement of youth appointed and persons with disabilities who are dismally below the target? And my third question, how are internal audit processes strengthened in relation to recurring AG audit outcomes to assist with internal control that will result in the improvement of the AG audit outcomes to an unqualified with no findings outcome? My fourth question, in which regions have youth zones been expanded, and what is the interaction rate versus improved impact regarding STIs and HIV infection rates in areas with youth zones? And then coming to my last question, the Northern Cape seems to have a number of challenges which the department cannot account for sufficiently, such as the youth zones and the non-implementation of the audit plan. How is the department supporting the province, and what are the main causal factors? And those are my questions. Thank you, Chair.
Thank you, Honourable Chairperson. Good morning to the Honourable Minister, the Deputy Minister, officials from the department, and honourable members. Honourable Chairperson, I've just got the following for the Minister and the department. Honourable Minister, on the treatment of cancer, we know that the cancer statistics is shooting through the roof the past year and the past few years. What programs will your department launch to make awareness around cancer like we did with HIV and TB, so that people can become more aware of it, and that we can have a very good service regarding oncology services? The reason why I'm asking this, because I'm receiving complaints the past few days that there's cancer patients at our hospitals who's on a very long waiting list for almost 2 to 3 years to be getting treated. So I just want to know what measures will you and your department put in place to sort this problem out faster, so that these oncology patients can get the help they needed so much. Then on the press conference you held yesterday in Centurion, you've spoken about the production of vaccines, or the improvement of vaccines for polio, etc. I think you've said that it will look at a cost of 3.5 billion. I just have a question regarding that. Will that vaccines be produced locally by our own laboratoriums here in South Africa? And then on the occupational health, OHSC and the Health Ombudsman, when will you foresee an increase in the budget for these two entities? They urgently need adequate office space. They must appoint more inspectors and other staff members in order to do their work properly. And then the past week we hear from the Auditor General that there's no improvements to audit outcomes for certain provinces like the Eastern Cape, the Free State, the Northern Cape for more than 4 consecutive years. And we've heard about material misstatements identified for Gauteng, Mpumalanga, and Northwest, and that critical positions is not filled timelessly with regarding the right skills, and that there's a lack of internal controls, a lack of oversight. I just want to know, how will this department see to it that these sort of problems will be eradicated? And upon that, can we as a committee please get an explanation regarding the fruitless and wasteful expenditure and the irregular expenditure of this current financial year? But I just need to bring something under your attention, and then I'm finished. I received last night news from out of the Pelenomi Hospital that there's no stock in the pharmacy. There's no medicine in the pharmacy. Apparently, there's a delay from the depot, and the pharmacy is completely out of stock. if the department can just give attention to that, please. Thank you very much, Chairperson.
Member next, Cherwa.
Thank you, Chairperson. I thought I was after Baba. Apologies. Greetings to the minister and his team and to everybody that's in the meeting. Greetings to my colleagues as well. Minister and your department, firstly, let me address this issue that I've been addressing with most of the entities that I've presented in the portfolio committee this week. I think I've been misunderstood this entire week on what exactly I'm currently proposing, right? In terms of research around this particular issue and in terms of investment and eventually like a proper sustainable campaign around addressing this particular issue. I hear the department speaking about the fact that the indicators of maternal and infant mortality show that there's a reduction, right? But I think we're missing something gravely important in this whole conversation on maternal and infant mortality, especially infant mortality that happens in public facilities and the issues of injuries. If the case does not result in mortality, the growth of injuries occurring during births to children who then have to live with permanent disabilities that can be countered by increasing C-section capacity. And I'm stating this because even the failure, mortality, that if it doesn't happen, then it's an increase in injuries. This is indicated also by the litigation cases in that particular aspect. And from my perspective, Minister, this is now a human rights issue that we've got women who have healthy pregnancies and then ngama-last minute ey'bhedlela makumele bazale noma bathole ingane, and then kuba nama-complications, either baba distressed or something like that, and then they cannot be assisted with.
Chairperson, I'm not sure that I'm the only one who have lost the member.
Honorable Cherwa. We will go on to the next.
Because I'm at least doing more public facilities. I'm speaking as somebody who has also experienced this to my son. It becomes, pardon? Sorry?
Struggling to hear you.
Let me continue.
Anyway.
Oh, can you hear me now?
Yes, better. Thank you.
Okay.
Please continue.
Okay. So, yeah, so Minister, I really want us to just engage without being provocative or anything, but really look at something that's going to be sustainable in increasing C-section capacities in public hospitals, especially in rural areas. You even look at the case of Eastern Cape, nama litigation cases wabo, and the issue they have with children, abalimalekayo, ey'bhedlela. And it's not even the correct reflection of what really is happening, because like with myself and many other women, there was a lack of knowledge and information that we didn't even opt to sue the state or to sue the NDOH, but we took it as maybe just, a mishap that happened or something that was God willing, until you get information as time goes. Actually, this was a case of negligence. This was a case of the fact that the state was incapacitated to carry through these procedures as per when the need arises. So please kindly look into this issue, and maybe, I would be very pleased if the department was able to spearhead a proper campaign, a proper initiative that looks at increasing the capacity of public hospitals to be able to carry through C-sections and to be able to respond to issues that rise during the births of infants. The fact that the children are not dying is not an indication that it is becoming better, because we are taking back home children with cerebral palsies, children who suffered from hypoxia, things that could have been avoided in that moment of birth. And then number two, I got a report that the department has requested the closure of establishments that take in, those drop-off areas where people drop off their children who don't want children anymore, instead of killing them, leaving them in dangerous places or putting them in the drains. But I want to hear from the department, because I didn't think it was true when I first saw it, especially because we know how beneficial these establishments are. If anything, there should be a collaboration with the department and these facilities and establishments, because the result of these places being closed off would be dire for the very same children either way, because they will continue being abandoned. Just by the way, it's like with termination of pregnancies. You don't take away abortion because of morality or whatever. You increase it, you make sure that it's accessible, because women are going to abort either way, whether it's legal or illegal, right? So please just clarify that. And second to that, I just want an update. I had asked the question to the minister on the issue of child, let me not call it teenage pregnancies, of child pregnancies that result from rapes. And I've seen articles and the response from the minister on the intention to have these cases being reported to the police. If the minister can just give us a direction, because it doesn't feel like a solidified response or narrative. If you're still testing out the conversation, please also clarify that. And also on the SAMRC, Minister, banenkinga a transformation in that entity. And we spoke about it when they were here in the committee. We've been speaking about it for the past 4 years with the SAMRC on the issue of transformation when it comes to race and senior management. They are able to get the other parts of it right because they're able to increase women and the number of women that they've employed in a very good manner. So they are not unable to transform the entity in a beneficial way, except when we're talking about the impact of that transformation. But when it comes to race, they are doing extremely, extremely bad. And I think at this point, it needs political leadership more than it does need executive or management leadership. It needs political direction that comes from the office of the minister to have an instruction that this must be happening, because at the pace that they're currently going, so if you are 50-50 of senior management with Black people represented at a 50-50 level after 15 years. And this is concerning for an entity that has a program to address issues of transformation, but is still doing so regressively bad. So I want to ask the minister to look into that as well, and to provide political leadership to the entity. And on the issue of unauthorized expenditure, Minister, I think you'll also agree, this should automatically result in criminal charges and or disciplinary hearings. So I want to find out from the minister and the department if this is the case. And if it is the case, where and in which instances has this corrective measure been taken by the department? And if it's not the case, can you please also expound and appraise the committee why this is not the case? Because we can't have issues of unauthorized expenditure when we have issues of money and management of money in the department. And it's criminal. If it's not criminal, there must be some level of investigation of clearing these particular things. There must be a consequence management system in place that kicks in automatically when these things happen. And lastly, Minister and the department, please provide an update on your mental health strategic framework. Thank you very much, Chairperson.
Kaba. Honorable Kaba. We will go on to Honorable Thembekwayo.
Thank you, Chairperson. My question on oncology patients has been asked already. They'll go to the second one. When we visited hospitals in the Eastern Cape recently, we realized that they had a very serious infrastructure dilapidation problem, including shortage of staff. Because the National Department of Health representatives were also present, I just would like to ask the minister whether they gave him the report and what has he done to help alleviate the problem that is experienced by those hospitals that we have visited. Yesterday, when this group that was here, the Council of Medical Scheme when they do in their presentation, they mentioned something very disturbing, to say they are given a role to develop a funding model, which will help in the NHI, as it is mentioned. But they said to us that they have realized that it's a very complex and difficult project to do. I wonder whether they have reported to you, Minister, that this project that you have given to them is complex and difficult. That's why they can't complete it. And if then is the case, what is it that you intend to do? Because it plays an important role in the NHI model. The same applies to the fact that they said it's difficult for them to secure an appointment with you. Is that so? And what about the issue of emergency when people need to see you in connection with the completion of their projects? Thank you.
Thank you. Honorable Clerk.
Thank you, Chairperson. I do apologize for my situation today. They're busy painting my home, so I couldn't have my meeting there because it's chaos. Can you hear me clearly?
We can hear you.
Thank you very much, Chairperson. It's still good morning. Good morning to the Minister and the Deputy Minister, and thank you for the presentation. Mr. Minister, you know, I'm going to say this ad nauseum, but I still want to know how we're going to fund the NHI. You know, in terms of our economic environment we find ourselves in, and what the Finance Minister and the National Treasury is saying, when it's talk about having to hike VAT and having to hike taxes, and this country, citizens of this country is really squeezed. They barely can put a plate of food on the table for people, for their families. So, I mean, we're really not in an ideal situation. And yes, I congratulate the department for getting a qualified audit. But there are certain areas where we haven't done well in terms of expenditure. And that is quite worrying. You know, the conditional grants, 2.3 billion rand underspent, HFRG 752 million rand. And I'm really concerned about the provinces that have not received qualified audits, and I think we must really ensure that these provinces come and account to the committee, Chairperson. I mean, if I look at Gauteng, I think they're one of the biggest problems in terms of their audits, and I think they really need to come and account to us. I also noted that goods and services, 41 million rand underspent. I mean, and that's why when we do oversight at hospitals, we often see that hospitals don't have enough food supply to pay service providers in order to ensure that the patients are fed properly and have a proper balanced meal. The following questions I would like to ask: why were there no intake of learnerships and internships over the past 2 years in the Program 1 of administration? What is the deadline for the South African Law Reform Commission inputs on the discussion papers regarding medico-legal claims, and what is the estimated timeline for completion of the paper after the inputs have been received? What is the current situation with medico-legal claims throughout the province? We are regarding the NC not having a focal point manager for the 1990 HIV/AIDS program. What is being done in this regard? Regarding the TB treatment program, what are the reasons for the poor data capturing into the electronic system, and what is being done to address this? How many primary healthcare facilities do not have operational managers? and how many of those vacancies are being advertised currently? How many facilities as percentage have ideal clinic status, and how many in each category? Because as we all very well know that this issue is a very important issue to align with the NHI bill. And, we have been told during this week from the entities their staff constraints in order to reach these targets. How will the NDOH motivate the provinces to appoint operational managers? The National Planning Commission 10 years review of the NDP from 2012 to 2022 recommended that the NDOH undertake a skills audit to identify the number of medical professionals who need to be retrained, as well as the funding requirements for the training program. Has such an audit been done, and if so, what are the outcomes, and if not, why not? The review also recommended that government consider the governance limitations of the NHI bill prior to its enactment. How did you do with this issue? It was also recommended that the NDOH and the Department of Social Development strengthen integration between health and social services. What is being done to achieve this, and how is it being monitored? Who is being held responsible, and what steps are being taken to rectify and prevent unauthorized, fruitless, and wasteful and irregular expenditure? What consequence management actions have been taken against whom, and what were the outcomes? Please explain the reasons for the unauthorized, fruitless, and wasteful and irregular expenditure. Specifically, has there been any disciplinary or criminal procedures regarding unauthorized expenditure? Is the department playing any role in addressing high levels of irregular expenditure with provincial departments of health, which have increased over the past few years? Regarding the digital vibe saga, have any monies been recovered in terms of that? And then just a couple of things on the AG report that was presented to us. Why were financial statements submitted for an audit again not being prepared in accordance with the prescribed financial reporting framework and supported by full and proper records? The AG noted that leadership did not exercise oversight responsibility regarding financial and performance reporting and compliance, as well as related internal controls, which resulted in material misstatements and material findings reported in the audit report. How is this being addressed, and what consequence management action have been taken regarding this? How is the department dealing with accruals, which is a big issue in the health sector? Has the department assisted provinces in dealing with their accruals? What is the department doing to lead the sector in dealing with poor audit outcomes, which reflect that management is ignoring or not applying the law and regulations as stipulated? Why was the targets related to provincial departments receive clean audits being removed? What is being done to improve the audit outcomes to clean audits? What support is being provided for the provinces? The AG has for the past number of years raised issues with regarding to the quality and reliability of data that the department presents in their annual reports. What is the department doing to properly define the outputs, data resources, and ensure that data collection and reporting is reliable and valid? Please update the committee on how the department... Yes, yes, Chair.
By your 20th question, could I suggest you send some of those to the department to respond with writing?
I will do that because I've got at least another 20 questions.
Yes, please. Please do that.
I'll do that. I'll do that.
Thank you.
Okay, I'll do that, Chairperson.
So next is Honorable Kaba, if you are back. If not, Honorable Harvard.
Chairperson,
you later, Honorable Gela. I'll give you later. Honorable Howard now.
Thank you, Honorable Chair. Really appreciate the presentation from the Minister and the Deputy Minister and the team. I only have 3 questions. The Eastern Cape continues to struggle with complaints and thus affects the performance of NDOH. What progress has been made in this financial regarding addressing interoperability between the provincial system and the national case management system? My second question, what fundings are coming out of the case management system to manage medical legal claims from Gauteng, KwaZulu-Natal, Free State, Northern Cape, and the Northwest? My last question, Chair, how robust are the recruitment mechanisms and the NDOH succession plans to ensure staff equitably is not lowered due to resignations and retirements, as evident in the gaps between the targeted of 50% of women at the SMS level versus the actual performance of 46% of women at the SMS level? I thank you, Chair.
Thank you, Chair. May I please just start off, first of all, by saying thank you so much to the department for their presentations. To the Minister and the Deputy Minister, this is my first foray in the Health Department, so please, if you will indulge me, I would appreciate it. I have one request to make to the people who create the presentations. I am a lexiphiler. I am a fanatical grammatical error person. There is a difference between personal and personnel. There's a difference in the name, there's a difference in the spelling, and there's a difference in the meaning. When you're talking about personnel, it's PERSONNEL. Please, will you check the spelling in your reports? And there were a number of spelling errors in the reports. These reports go out. It's a very bad indication on the department if these reports are not spell checked. There are grammatical and spelling errors throughout the entire reports. Please, may I ask that somebody does a spell check on these reports? You have words like resources with an S in the middle of resource left out. It makes no sense. To get on to my actual questions. On your finances, the NDOH has a budget of 64.6 billion rand, of which you spent 62.9 billion rand. This was an underspend, and yet we have healthcare facilities that are crumbling across the country. I cannot accept that you have an underspend of budget, irrespective of which program it comes from, and you have healthcare facilities that are crumbling. You have patients who don't have food. You have pharmacies that don't have stock, and yet the national department is underspending on its budget. A lot of my comments are going to be quite broad. Like Honourable Clark, I have hundreds and hundreds of questions. These will now become specific questions that I will direct to the department. I'm going to pick up on a couple of them. With regards to the COVID-19 vaccines and the fact that there hasn't been as much of an uptake of the vaccines that the department would have wanted, how many of the vaccines that were procured have now had to be destroyed because they have now either passed their sell-by date, are about to be destroyed because they're about to reach their sell-by date? What has the department done to destigmatize the use of a COVID vaccine and to challenge the message of anti-vaxxers around the country? What have you done to actually make COVID vaccines available? I needed a COVID vaccine in July of this year and really battled to actually get my hands on one because there was nothing really available to me. I really had to search to get one. And I found it quite inconceivable that I had to go overseas on government business and I had to battle to go and get a booster because I'm over 65 and I felt it was necessary for me to do that. Turning to the AG's report, I was quite horrified, I must be honest. There was an unqualified audit opinion, that's fantastic, but there are material misstatements all over. This is mentioned right across the AG's report wherever you look. Corresponding figures for the 31st of March had to be restated because of errors in the statements for the 31st of from the 31st of March 2022. Leadership not exercising appropriate oversight, no implementation of proper record keeping for complete, related and accurate information that is available to support financial and performance reporting, no controls implemented over daily or monthly processing, no adequate review reporting and performance reports. Actual achievements were achieved, not supported by appropriate evidence. This is from the Attorney General. No adequate review indicators and targets to ensure that definite planning has actually been taken. Material findings on usefulness and reliability of the reported performance information in Program 2, which is the NHI, the AG was unable to find evidence that 85% of the funded posts were filled, and it was likely that the target was not achieved. In the AG's words, Program 3, communicable and non-communicable diseases, the AG could not determine actual achievements of facilities offering the HIV self-screening. Materializing that the reporting was, she said that the AG said that it is very likely that the reporting was less than was said to have been achieved. What is the consequence management for irregular expenditure, for fruitless and wasteful expenditure? The AG is concerned with these findings and these material misfindings. Again, reports back to the digital vibes. Who is actually being held accountable? What is being done to recover the monies? The NDOH, what are you doing to address the controls and address the risks for wasteful expenditure? The department's performance has declined with only 30 out of 52 targets achieved, yet 97.4% of the budget has been spent. That concerns me immeasurably because in 21-22, 62.8% of the targets were achieved on a 98.8% of budget spent. We have dropped the number of targets achieved and yet not dropped in any significant manner the amount of money being spent in the same period of time. These are highly concerning. If you think that we are now going to be able to implement the NHI on a reduced budget, and yet we are spending more and achieving less, it's frightfully concerning for me. The targets for provincial DOH have been removed. Why? The provinces are not meeting their obligations. We are not able to track what they are doing, and yet their targets have been removed. How are we addressing the medico-legal disasters that we are facing on a daily basis? The medico-legal claims are climbing exponentially. We know for a fact that before a provincial department is able to exercise any of its budget, such a great proportion of their budget is spent on medico-legal claims, and they are left with such a small proportion of money in which to have an operational budget with which to operate their hospitals. That is why the Eastern Cape is falling apart at the seams. It's ridiculous. How can you run a budget when so much of the money that you are allocated is then having to be spent on medico-legal claims from a previous year? You need the budget that you are given to operationalize your performance now, not to pay historical medico-legal claims. We have to do something to address medico-legal claims or adjust the budget of the province accordingly so that the province can run the functions of a health department. You cannot expect a province to have a health department if you tie their hands either in front of them but locked so tight that they can't do anything, or tie their hands behind their backs. It's impossible. No wonder there are so many problems in our health departments across the country. How does load shedding affect the chronic medication dispensing and distribution? If you look at insulin, for example, not all the sites where people can get their chronic medication has a cold chain. How does someone who has to get insulin, which has to be kept at a regulated temperature, know that the insulin that they're getting is still valid? That's a major problem for me. And if you're going to implement this extensively in terms of the NHI, where we decentralize the collection of chronic medication and the load shedding continues unabated, how do we know that the medication that is getting to the rural areas is still being maintained and is still useful in terms of the cold chain? NDOH, again, poor uptake of COVID vaccine program. What strategy is being employed to encourage people to take the vaccines and to counter the anti-vaccine messages? In terms of program 3, not one marker of the TB program was actually met. That is a huge problem. Not one marker was actually met. I'm going to leave it there, Chair, because I still have so many issues, but I will put them down in formal questions. Thank you very much, Chair. I will leave it there.
Thank you very much. I'm now handing to Honorable Morane, and then I will go back to Honorable Kaba.
Thank you very much, Chairperson, and also to indicate that the very comprehensive table by our Minister before the Portfolio Committee.
Morane, you can switch off your camera. We've now seen you, and I see you struggling with the bandwidth. So you may switch off.
Thank you, Chair. Thank you, Chair. As I proceed, I only have a few questions that I want to ask the department, as the Honorable Minister and the DM are here, and the entire team. The first question, Honorable Chair, is that noting that about 40% of the infrastructure problems are identified as having challenges, what capability does the department have to project management and monitor infrastructure development effectively? The next question, Chair, what interventions have been made on contractors who do not meet the required standards as per their service level agreement, and how effective is the contract management by the department, not some of the poor outcomes? And the next question, what is the human resource complement in healthcare institutions in relation to people seeking mental health care? And how are digital and global mental health programs being utilized in managing limited professional human resource to ensure continuity of care? How are IT or cybersecurity strategies being improved in the financial year, and what partnerships have been pursued to complement these efforts? Chair, I'm left with only 2 questions. How many internal disciplinary cases have been opened, and what the status of those cases as part of implementing consequence management on the poor governance translated into the audit outcomes? And my last question, Chair, to to the Honorable Minister and the team, how many investigations have been undertaken regarding irregular expenditures, and what steps have been taken against the findings? Thank you very much, Chair.
Thank you very much, Honorable Kaba or Honorable Gela. You raised your hand earlier. Honorable Kaba, are you here? Honorable Gela, did I understand you wanted to raise questions?
Chair.
Honorable Kaba?
Chair, I think this
Yes,
is
I'll
my
take you
turn.
after this, Honorable Sengwa. All right, let me give you your turn, Honorable Sengwa.
Thank you, Chair. Greetings to the Minister and the entire department, and passing the condolences to the Shenge who lost his father. In the financial year 2022-2023, the department had 51 set targets. How many out of these were achieved? What new challenges did you face which prevented you from achieving 100% of your targets? And what steps have you taken to correct this so that the department should achieve 100% of its targets? Were there any challenges that you had faced previously that you encountered during the same period? Lastly, how many hospitals did you assess in total, and what were the findings for each? Thank you.
Thank you, Honorable Kaba or Honorable Gela.
Chair, can the hoster unmute Honorable Kaba? If you can check the portfolio group chat, he posted that he is unable to speak. If the host can unmute him.
Yes, can you please unmute Honorable Kaba, the host? Can you please do that? Try now, Honorable Kaba.
In that case, Chair, if he's still Chair, Chairperson.
Yes, Honorable Gela.
Can I
Yes.
take
Is
his
there any
questions?
questions which you would like to then ask on his behalf?
Yes, Chair, I'll do that. Questions from Honorable Kaba, Honorable Minister, as follow. Noting that the department has a significant number of clinics which are identified as not an ideal, what is the focused strategy and plan to close the gaps as part of preparing for the NHI and to improve the quality of healthcare services? Secondly, noting the recent census on the population growth and the level of migrants, what is the estimated impact on the quality of healthcare provision, and what strategy can be enable the department to negate the impact of cost containment measures and the lowering fiscal declines? The other question, what lessons has the department learned from the COVID-19 experience in relation to human research resource optimization of health professions, and how are these lessons informing the functioning of the department and the health facilities? The other one, what is the extent of digital healthcare provision in South Africa, and how can this alleviate the demand and pressure in our healthcare system? What opportunities does artificial intelligence have for the health system, and what plans is the department having in this regard? The other one, what is the extent of infrastructure maintenance as a percentage of the infrastructure spend? What was the extent of late payment to suppliers, and are there cases of payment beyond the 30 days standard? Lastly, Chair, what financial implications have been experienced due to the low demand for COVID-19 vaccines in the program 3? Thank you very much, Chair.
Thank you very much, honorable members. I am concerned, Minister. I think you probably now have 100 plus questions. So I'm going to be restricting some of mine. I noted that the members touch on almost every matter that had been raised by yourselves and by the AG. So there is very little that I can talk to apart from what they've raised. I've got one or two points which I maybe want to just talk about. The one is about claims against the department. And the understanding is that 75% of the budget is already at risk. And so the question would really be, what are the financial risks which can be caused by this? And what is the reliability and appropriateness actually of the claims which are raised? So now I'm not only talking about medical legal claims, but claims in general, whether it would be interest on late payments, and this is throughout the sector, and whether it would be delayed projects or from the department side or the sector side, or probably for the entities also where, for example, of infrastructure project, there are challenges. And then it's been raised quite strongly, but I just want to reiterate here that we raised with the entities the challenge of irregular expenditure and what needs to be done. For example, NHLS, the AG was awaiting application for condonation, and the NHLS explained the position yesterday, but we'd hope that they will move forward with the condonation request. And the fact that the CMA's 59 million rand is still under investigation, and we'd like to see that those investigations come to an end, that there are these matters are resolved. And then for the NDOH on the consequence management to the tune of 359 million rand. Then in terms of root causes for that, it has been said that these are really four things which contribute. It's proper record keeping, which needs to be maintained, financial and performance reports, which need to be prepared and improved upon, daily and monthly processing and reconciliation of invoices, payments, and reporting, and then compliance with the relevant laws and regulations is a bit of a challenge, and there's actually five, and the last one is IT governance. So those are, and then of course I already mentioned with infrastructure, in particular, the challenge of delayed projects, which a lot of the members have already spoken to. Just for noting that 69% of the 35 projects audited had findings on delays and 40% had both quality findings. These are very difficult matters, of course. And I, for one, would understand that it is not easy with all of these challenges to be able to manage this and report on all of it. And so a lot of the questions really, and even some of mine and the points which I raised, are matters which can be raised again in the future, matters which can we can receive written replies on, etc. But also on the expenditure accruals, where currently it stands at 19%, the question is, what implications would the 19% expenditure accrual have on the financial capacity of the department to optimize an appropriation? And what is the plan of the department to address this problem, as some provinces have close to 50% accruals? We are fully aware of where this is happening, and we are hoping that there will be urgent interventions with regards to these. Another intervention that is required is with the Northern Cape Department of Health, and I'm hoping that the department would be able to do an investigation and then provide us with feedback on that investigation and come with recommendations on what it intends to do to solve the challenges which are being experienced by the Northern Cape Department of Health. I think it's come to a point where there needs to be a very, very serious intervention. And then in terms of the Health Ombud Bill, the progress with that would be great to hear. Where that is, because surely, as we understand, that is partially what leads to the Health Ombud challenges with inadequate resources on many fronts. And then just to make for the minister or the department, I think must make a distinction between the NDOH ICT department and the digital systems development in the NHI branch, so that any misunderstanding which was maybe given to the portfolio committee can be addressed. And lastly, maybe on a couple of more things, as I started with the recommendations, is that the record-keeping systems I've mentioned, I am of the firm belief that a lot of our challenges on medical legal claims is really because of our record-keeping systems and our ICT systems. And the big question is, when are we going to able to get one unified system where all the provinces and the NDOH should be utilizing one system, which really works? And record keeping here, I'm not only talking about medical record or records within hospitals or facilities, but also in terms of financial statements. Then consequence management I've addressed. The other challenge, of course, was the challenge of funding for the ideal clinic. Realization and I think it was maintenance program. Ideal clinic, realization and maintenance program, and the fact that there is not funding or enough funding allocated to it. And then I've spoken about the last one, or second last one, would be a strategy of optimizing the compensation budget for posts in the healthcare system. This is something that is very, very, very critical. I sometimes speak about a shell. One is a shell, which is that infrastructure, and inside that shell, it's like furnishing a home. You need to have those things which matter so that we are able to give services. It would of course be, firstly, be staff. It would be the staff who are suitably qualified and trained in order for them to be able to render the services. And then the shell needs to be in a very good condition for us to be able to deliver the services to our people. Is there an intention to develop a reprioritization strategy to optimize conditional grant spending for the sector? And it would be good that there will be a pipeline of projects which are ready for implementation if they are allocated funds. We should also look at the what was raised. I raised it earlier, the supplier payment monitoring. I would suggest, we as a portfolio committee would suggest that be done on a bi-monthly basis. A financial strategy of reducing accruals by 10% annually should be put in place. And we suggest that the recommendations of the AG be implemented. We also suggest that the department should do quarterly monitoring and resolve issues of non-compliance with the NDOH, CMS, SAPRA, and NHLS. And I've spoken to consequence management and I've spoken to the challenges with the Northern Cape Department of Health. And us as a portfolio committee, we should strengthen our oversight. And I'm speaking to my members here, particularly on performance reports, to continue monitor infrastructure development, and we should keep our eye on improvements of the record-keeping systems. Thank you very much, Minister. So that I know many questions. I also understand within the allocated time, we might not be able to get all of the responses and answers. I said earlier that you're very welcome to send some of these responses in writing, and I would ask the honorable members to exercise indulgence with what we are doing here today and what we will be doing in the future. And thank you very much, honorable members, for the wonderful way in which you've interrogated the presentation and made your points very clear. Over to you, honorable member.
Thank you very much, Honorable Chair, and thanks to the honorable members. Indeed, it's true, Chair, Honorable Chair, as you've said, there's probably over 100 questions here. Some, of course, they do overlap. So let me upfront just say to the members, honorable members, that where we may not be able to meet your expectations, as the honorable chair has indicated, we are always available. We are quite well endowed with written questions. At the current moment, honorable chair, by the way, indicate that in cabinet we are the leading department in terms of written questions by far, compared to any other department. So that opportunity, including oral questions, if we don't meet your expectations today. So I'll deal with some and then just ask the team to take up. I will ask from the DG that the issues relating to digital health systems, quite a lot have been mentioned, including cybersecurity. Between Professor Nicholas Crisp and Ms. Melanie Volmarans and the team, who are our experts in this area, they could deal with that. But let me just go on. A number of questions have been raised about the whole area of medical legal. And let me include from Honorable Gela and a number of other members, almost without exception, have raised issues on this, which is true. It's a matter of concern. It's a matter which we're giving our attention on a almost daily basis. It's a permanent item on our National Health Council meeting with all our MECs, including the meeting we had yesterday. So we're working together on this. The 75% of budget at risk, I know the Honorable Chair mentioned, it's true. The contingent liability runs into hundreds of billions. Now, our focus is we have no control over some elements of the actual submission of claims to the courts, but where we have control is in terms of the reducing the opportunity for claims. And in this regard, I'm dealing with various issues raised by various members. So our case management system, it's a comprehensive system of prevention, and then in the event that there is a claim, how do we adequately utilize various interventions? So on the prevention side, Chair, for instance, the matter you have mentioned about, reliable record systems, health information, especially patient record systems. So that's a matter which we're giving, a very urgent priority. Members, some who have been in the health sector will know that the issue of aspiring for a national kind of, a system, or at least an interoperable system, has been with us and has really eluded us for many years. Since the dawn of democracy, I'm aware that this matter has been a subject of discussion at the national level. Ministers before me have actually been trying to coordinate this. We do have, and in that regard, in terms of the record system, Professor Nicholas Crisp and Ms. Melanie Wolmarans will on allocation by the DG. I hope they can come back and say a little bit more comprehensively, because it's a matter which has been raised. So that's one very key aspect. That will, if we can make sure that our record system across primary right up to the highest level of care, it's digitized, and because quite often records, because there is the definite areas with Honorable Chirwa mentioned where there is medical negligence, clinical management kind of negligence, or inadequate clinical attention. And so that's an area we must deal with. But also, there is also collusion, and there are times, incidences where this has been confirmed from our own staff in health facilities who steal the physical paper records, so that and provide that to the litigants and the legal representatives. And when the case comes, when the hospital managers are looking for the records, they can't find them, and they surface in the court where the lawyers have a copy, and the health department of a particular province and the hospital don't have a copy. So the digitization, it's very key in this regard. Also, this collusion goes, there's been some times when it has been traced even into the offices of the state attorney, where this collusion has also, but nevertheless, we still have to use those systems of state attorney. This is just the bad apples here and there. So there is a huge contingent liability just on the medical legal claims, excluding what the chair mentioned, also other claims. But these interventions are reducing, from the record keeping system to the actual medical and legal improvement, communicating from ourselves at the national office and the provinces, so that many of these cases, then you don't get a judgment, a default judgment, where a particular judgment is given and an allocation is approved by the court because the case has not been defended. So those are the kind of things which the case management system is dealing with. It's not yet necessarily perfect. I think it's also, of course, our dispensation is not easy to coordinate because provinces, in a way, as much as health it's a service which within the constitution it's a shared responsibility between national and provinces, but there's certain the operational aspects are really at province. But we do get fairly good cooperation, but in terms of making sure that we move speedily, sometimes not everybody moves at the same speed. But I want to assure the members that this is a matter which we take very seriously, and we're doing everything to make sure that it will be reduced, if not totally eliminated. We are also pleased that there has been court rulings, which some are being appealed, but we are also joining the provinces which, like the Eastern Cape and Gauteng, where the High Court have ruled that because the biggest expenditure on the medical legal litigation is future medical costs. So there has been rulings which have made allowance that the public health, if our public health providers can prove that we have the necessary ability to look after where there's been a ruling of medical negligence and there's particular medical care required, that if the patient can be looked after in the public health system, then the courts have allowed that should be so, which reduces quite extensively the cost of even where there's been a negative finding. And there's already been cases, but we know that some of the lawyers are approaching the appeal court to appeal against this judgment. But that is very helpful in terms of reducing from this high levels of contingent liability to reducing the actual liability when courts have ruled. Just quickly on the issue on the youth employment, closing the gap, because of the financial pressures, issues such as internships and so on, some of those have been reduced or even delayed, which, as we said, on the youth employment would maybe make us get closer to the target in terms of the 30% of young people. But because we are, as we said, because we are not the front line service, for instance, in the front line in the hospitals, the employment of interns and concepts you'll find that the institutions which are frontline services will be much closer to meeting the targets of more young people. But in our situation where largely coordinating and policy and we need a more stable workforce, and therefore the issue of youth, except in the area of internship, becomes quite limited. The gender parity, it's the number of comments which have been made by members here. We indeed, this one, as you would see, that we are not far off. We're at 46%, and that is doable with a little bit, of just adjustments in terms of retention strategies, proactive training, and empowerment of because we do have at the middle management level, you do have quite a huge cohort of female, middle managers. So it's a question of also, empowerment, training, and making sure that more opportunities are created. The youth zones, I think, in terms of exactly where they are, this is a matter which we can come back. This is what we are promoting in terms of closing the gap between the young people who are not coming forward for testing, and also in terms of just ordinary, issues of family planning, dealing with teenage pregnancy. So it's a comprehensive service which we're making sure that each and every district does have a number of especially primary health care facilities which provide youth zone services. But in terms of the actual numbers, this is part of those kind of areas, Chair, where we will be able to make available in a written form to the committee. Honorable Van Staden, in terms of cancer treatment, we are putting quite a lot of resources as part of, you would have had when both the DG and the CFO were reporting that within, thanks to also support from the Treasury, that within our conditional grant on the NHI, we also support provinces to make sure that they can provide where they don't have oncology services, but also in terms of awareness programs on the communication side, on the health promotion. It's an area also which we are putting significant resources, also working with some of the NGOs. Many of you would be aware of an NGO called Pink Drive, which is very strong on the advocacy and also on screening. We work with them and other NGOs. There are a number of them, but the Pink Drive is one which is really very active, not only in advocacy and awareness promotion, but also including screening and testing for breast cancer, for also mammography, and also in terms of cervical cancer, and even also doing PSA also for prostate cancer, which is also quite a major burden. So there's a lot which we can do more, because you're correct that there's a long waiting list for those who are already needing services, but also cancer. There's an explosion amongst the entities of cancer, so we need to do a lot more. When we mentioned about spending in the region of 3.5 billion nationally, from national to provinces on vaccines, this is what we are committing already. And so due to various ways in which we try to take opportunity when there is a possibility of changes in particular vaccines, and where we are stable in particular way, where we can move to still very safer vaccines, but at a better cost, by making some savings here and there, while not risking in terms of coverage. We are able to expand the services, and we're just yesterday reporting after the NHC meeting, which have approved various changes in terms of our children's vaccine programs, in as far as pneumococcal, in as far as the measles and rubella. We're also adding a rubella vaccine into the system because of areas where, with some kind of smart purchasing, we've been able to make some savings. Rubella is very key because it prevents malformations of babies. The virus, if it can infect a pregnant mother, it can result in organ malformation of the newborn. So rubella is going to be also in the package of vaccines to be rolled out. The budget of the Office of Health Standard and Compliance, I think a number of members also, including the chair, raised that, and the Ombud. There are ongoing discussions. I know that in discussions with the CFO, we have looked at areas where, especially the Office of the Ombud, from particular savings where they could be able to get a little bit more additional financial resources in the current financial year. So that is being looked at. But the matter which the chair have raised about the Ombud bill, that has been, we have had to sort of put a hold on that, because with the whole issue of managing the fiscus, Treasury has been advising, but also at cabinet, broader cabinet decisions has been to reduce the number of entities for all departments. Because what is envisaged here with the Ombud bill will be to separate the Office of the Ombud from Office of Health Standard and Compliance. And because of that approach, policy decision that we should just hold on in terms of increasing number of entities. So this particular initiative for an ombud bill, where there had already been the beginning of drafting and in consultation, at cabinet level, and also with Treasury advising us to look at what cabinet has advised, actually that departments should reduce rather than increase entities, and see where functions which are already with entities can be done internally in departments or being absorbed by other entities rather than increase entities. So that is an area which we're grappling with, because definitely it would lead to creation of a new entity. The improvement of audits, a number of members have raised that, including at the various provinces. I think the CFO has indicated there are interventions through the CFO Forum, the National Health Council Technical Committee led by the DG, where various experiences are shared and also identifying common areas where provinces do struggle, some of which have been mentioned. I know that some members also went into the findings of the Auditor General in as far as credibility of information and all that. So these are the things which the teams led by the DG and the NHC Tech and also the CFO's forums are also dealing with. The DG and the CFO will speak to the issue of fruitless and wasteful expenditure in terms of consequence management. This also, the Auditor General has raised it on a number of years, especially in the last financial year, and there was steps which have been taken, which the DG and the CFO will be able to report on. Honorable Chair, the issue of improving the capacity of cesarean sections is definitely a matter which we are really, is on our radar screen, not only now, but over time. We know that we are not yet there, but one of the reasons for an initiative which has been there for quite some time, it's not necessarily stable in all districts. The district clinical specialist teams, top of the clinical specialist teams has been making sure that every district does have at the minimum, an obstetrician who is supervising all the maternity services in that district and providing leadership and training. Of course, we expect that the regional hospitals, for instance, should have qualified specialist obstetrician who will work with the district. But in some cases in the rural districts, very difficult to attract and retain qualified obstetricians. So the district clinical specialists, in those cases, we try and encourage that at the minimum, at least at the district level. And of course, it's not only obstetricians, but it means also anesthetists, but also pediatricians, because they work as a team. But also in terms of obstetric, advanced midwives, because they're also part of the team. So there's a comprehensive service which we are focusing on. Even at our level of the head office, we have said that we should improve our capacity to provide leadership in terms of people with advanced skills who can then provide national oversight and leadership in this area to reduce the burden of birth injuries, including cerebral palsy and other birth injuries. So thanks for raising that. We're definitely very much aware of this, and we'll try and make sure that we speed up our intervention. It's a matter which we are very clear that we need to improve on. The matter you raised about closure of drop-off areas for women who, for one reason or another, have babies who they don't want. That's a matter which we'll check because it does help if in some of our facilities such opportunities remain open, so that if for whatever reason, whatever social and psychological reason, a woman has given birth and doesn't want the baby, there should be safe ways in which they can leave those babies so that they can still be taken to places of safety, be looked after for adoption, and so that they can still be able to be saved. So it is a matter which we'll look at. The issue of underage sex and which leads to pregnancies, and which is clearly legally statutory rape. That's a matter which I know there's been a question also, oral, written question, which we dealt with recently, where we have made it very clear that to our facilities that any under 16 pregnancy must be regarded as statutory rape. The issues around the law, the fact that if the impregnating person, the man who's impregnating is actually not the man, but the boy of also underage, that's a matter which the law must deal with. But for the women, for the young girl of as they present, we must, from our health facilities, we must from the, in terms of the law, our health workers must take that as a statutory rape until the law, the legal people, the criminal justice system proves it otherwise. So that message is quite clear that in these cases, in terms of the record keeping, the referral to, the referral of such cases also as police cases, that must be standard. So that's what we have the instructions which we have given. The matter you have raised about transformation in the Medical Research Council, it's a matter which one will have to have a look at. I must say, I was not. I know that in as far as gender, they're doing very well. But the matter which you have raised about transformation, or in terms of race, it's a matter which will follow up and take it up with the board, with the board of the Medical Research Council, and see how they can improve in that. Unauthorized expenditure, again, the team will deal with. Mental health, we have an approved mental health strategy, which is being implemented. Maybe DG and the team could make some comments, but as you'll be aware that on the 10th of October, on Tuesday this week, was a World Mental Health Day, and we're really embarking on, making sure that mental health is profiled as part of the major programs within our health sector. And we have identified, even when we discussed with MECs even yesterday, we always put this as one of the high priorities, and looking at from the primary level right up to the specialized level. We do have backlogs, but we also have mental health explosion. As a result of post-COVID, the stresses which people have gone through, losing loved ones, losing jobs, and losing income, but also maybe one as a part of youth unemployment. We've just seen from the Statistician General about over 5 million young people not in work and not at school as well. So, and this leads to, it just fit into a high explosion of substance abuse, which leads to many young people clogging our casualty departments to be assessed, and later on some, with acute mental illness, acute psychosis as a result of substance abuse, and some of them then end up also clogging our mental health facilities, even chronic and long term. So we do have a mental health strategy which is being implemented. The Eastern Cape, Honorable Thembekwayo, the infrastructure challenges of the province are huge. We are working with the province. A number of facilities have already been addressed across. As about a month or 2 months, just over a month ago, I was in the OR Tambo district, where we're opening a brand new hospital. But there are a number of other areas in all the districts, including in the metros, even in the teaching hospital, Nelson Mandela Hospital in Mthatha, which also under the Walter Sisulu University as a medical school, a medical teaching hospital, which also needs some serious attention. But the number of facilities, so we are encouraging provinces that while we provide the grant, which of course I'll also just maybe take this opportunity to say, we were disappointed that the infrastructure grant was not spent in full. And of course, we're monitoring this now to make sure that money doesn't return to Treasury. Over 700 million was underspent in this financial year of reporting in as far as the infrastructure grant is concerned. And we are monitoring very tightly now. A big chunk of that came from Gauteng, which also needs, it was regrettable because Gauteng, as the health ombuds reported on Rahima Musa, Helen Joseph, a number of other facilities which needs attention. So we are attending to this, including in the Eastern Cape. But the backlogs are quite huge. But I must say to the honorable members that notwithstanding the financial pressures, we are discussing different models of financing infrastructure with Treasury, which will not just rely on the fiscus, but also look at what they call blended financing, including from private funders on certain terms, which can give us muscle to can then move big way into dealing with the infrastructure. So not only the Eastern Cape, but everywhere. The issue about the CMS saying that we've given them a task on NHI financing model, I'll ask Professor Nicholas Crisp to speak about that. I'm not familiar with, but the point which you say, somebody at CMS said that they are struggling to have a meeting with the minister, I would say it's very far from the truth. Just last week, I'm trying to remember whether it was Thursday, I think it was last week, Thursday, we spent the whole afternoon from 2 o'clock until past 5 with the full board of the CMS and all the managers. More than 3 hours, we went through an agreed agenda, went through a whole lot of items. So it might have been, if it's something which arose this week, I'll be surprised because just last week we spent the whole afternoon with the team from the board to the management. Honorable Clark had almost more than 20 matters to raise, some of which are matters which he has raised on almost every platform where we have met about how we're going to fund the national health insurance with the current financial pressure. I dealt with this also yesterday when we had the media briefing after the NHC. And the point here is that even while there is financial pressure, we're very pleased that the government, including Treasury, have been quite cautious not to put the health sector under too much pressure. We are surrendering some money, as we announced yesterday, on some of the grants, and a little bit also from the head office, as DG mentioned, just over 200 million. But there's been agreement that the equitable share to frontline services will not be compromised. What has already been allocated will not be reduced, so that will be protected. But also we're discussing with Treasury and at Cabinet a way to make sure that even funding the increase in cost of employment as a result of the adjusted the salary agreement of March this year. We're discussing, and Minister of Finance will make an announcement in terms of to what extent they will be able to also help, notwithstanding the current pressure, will help our sector, the health sector, to cushion us against the impact of increased salaries. So, but I leave that to the Minister of Finance. But in principle, there's agreement that they are going to do something to give us some cushion. So the health sector will feel the pressure in terms of reduced allocations, but it will not be as big as maybe it could have been. But we're also looking at the fact that there are other areas where there can be a lot of savings, but we're also saying that currently we know that in terms of the total, per capita spending, in terms of the health sector, in terms of the total what the GDP spending on health can actually provide, and it's a question of adjusting the formula of how we fund the sector, not the huge billions which some honourable members believe. There's a small addition which needs to be added on what we currently spend, even just the tax credits which are given to those of us on medical health insurances like medical schemes, which accounts to about 35 billion. That even just that amount, if it could be redirected to the public health, it would make us be able to improve the quality and be able to fund a whole basket of services. But I'm sure the details, again, as we do, Honorable Chair, we can discuss again these matters of NHI and the cons and pros for those who don't support. As I say, it's a matter which we talk about almost every time. Again, on the medical legal, the law reform process, law reform commission, we believe that within this either the current calendar year or at least within the current financial year, the law reform commission will give us a report which will help us to look at a legal issue, the kind of either amendments of the State Contingency Liability, State Liability Act, which falls within justice, or also within health if there's a new legislation which might need to be enacted. But we are already working with the Justice Department to make sure that the amendments which were to be made on the State Liability Act should actually be processed, so that some of the interventions which can help overall on state liability reform and amendment of the Act will help us also in the health sector. Now, there was a mention, Honorable Clark mentioned about audit of medical practice and retraining. I think it's a matter which will get more details, which we're not very clear. But the issue of the unauthorized expenditure, again, which also finds and financial statements not proper in terms of misstatements, the team on CFO and the DG will come back and deal with that. I think in a way, Honorable Harvard on the issue of the Eastern Cape, again, in as far as the performance of the health service in the province, just to say that we are working with the province there. There are a number of areas in the province is suffering very hugely in as far as medical legal claims, and we're focusing on that province and also Gauteng and the KZN, and which are big in as far as the medical legal claims are concerned, although it affects the whole of the country. Eastern Cape is bleeding, so we are working very closely with them to close that leakage. The accruals are very high, historical, but made worse by leakage from medical legal claims. So we're working with them to close that tap of the leakage of medical legal. And the chairperson has also raised the issue of the accruals. Unfortunately, Chair, as you know, that there is no provision in the current budgeting and funding for Treasury to bail out departments, including provincial departments. So provinces which are running at huge accruals, we just have to work with them to look at areas where efficiencies can be improved and leakages can be closed, so to progressively make sure that their financial situation can improve, working also with provincial treasuries. The number in our meeting yesterday, almost all provinces indicated that they are anticipating in terms of their quarterly expenditure, they are anticipating overspending without exception. So what differs is the quantum. So some of the provinces, their provincial treasuries are already working with them to see how they can reallocate funding. But overall, where this is not possible, we just have to work with them to try and make sure that we can reduce the risks and also improve on efficiency of the systems. Yeah, I think this I've already dealt with. Succession, Honorable Harvard, to improve the equity. I think it's a good advice, and I'm sure the team is listening. Honorable Hickling, I must be very careful how I pronounce your surname. You've already warned us about spelling errors. We will look after that, make sure that where they're in the reports, We know that many of us, including some of the officials, English is not our first language, but we should do our best to make sure that obvious mistakes are not committed, including spelling errors. And also the issue you've raised about underspending on key budget lines such as infrastructure, we agree with you that it's unacceptable, but it's also just, I think, improvement of planning cycle, especially on infrastructure, because to deliver on infrastructure, you need to plan ahead of time. So our team, we also are improving the capacity of our infrastructure team so that as we support provinces with infrastructure grants, we should also, the business plans which they submit, we must be able to guide in terms of making sure that when the funds are allocated, those business plans speak to the fact that they are actually ready. There's no use allocating R1 billion in April of a year when the planning is still in the very early stages, and you're almost certain that the allocation of the starting of the project is not going to happen. So those are the things which indeed we'll be working on. The vaccines, in terms of the quantum of vaccines and the cost of that, which are to be discarded because of expiry, because of low uptake. Professor Nicholas Crisp will deal with that. I think on the reliability of information, and also on where the issue of on the digital vibes, just to say that we did take steps in 2021. There were officials who were suspended, charged. Some, have already left the department. Others, there were particular sanctions which resulted in demotion and suspension from without pay for a couple of months, and some returned at lower levels. So there were a number of sanctions based on the outcome of disciplinary action which were taken. In terms of the recovery of the funds, that is a matter which the Special Investigating Unit is pursuing. There are particular procedures. We, as the department, on a matter like that, we are not the experts in that area. It is the SIU which is the expert in that area. The issue of non-performance on the targets, the significant part, as we said, the decline from 62 to just under 60, 59.6. As we said, it's mainly on program one. There are areas where, as indicated in terms of equity targets, which we have not been able to attain, which then reduced our performance. But also, honorable members, just to say that including on the issue of the medical legal interventions, many of those, some of those areas is also as in many areas of our performance measurement. We rely quite a lot also on colleagues in the provinces. It's a collaborative kind of process. So we work together, and if there's poor performance on the provincial counterparts, it affects our performance ultimately. But we are not passing the buck. We just stating the fact that this is the nature of the health sector and how it works. Whether load shedding does affect the CCMDD at the current moment, not really. There are medicines, insulin and vaccines, which are not part of the CCMD. Those which need cold chain management, they are managed strictly into the facilities which need a cold chain. So at this stage, all our facilities which need cold chain have backup generators. So we have not lost vaccines and other medicines which needs cold chain, which as a result of the load shedding. Load shedding is a challenge, but we have not lost medicines and vaccines as a result, because those facilities which must carry this are required to have backup generators and make sure that those fridges are running. TB, it is a problem, as the DG said in his reporting. We have a plan, a recovery plan post-COVID, which we are driving. There is an improvement, not yet at the level where we would want to be, but this is, of course, being attended to. On infrastructure projects and management, again, we are improving our capacity, both at national, but also at working with the provinces in terms of contract management, project management, to make sure that we don't only just spend, but we must spend on quality. And we have also been emphasizing that we are spending too much. The cost of infrastructure in the public, including in health, is quite high. There is no need for always to redesign. If we talking about district hospital, we are pushing now for modular planning, where a CHC module of a design should be, so that you don't start from scratch every time and then spend a lot of time and money on design. So those are some of the things which we are changing to make sure that we can deliver quicker, but also at right quality and right cost. The issue of disciplinary action on the issues of findings of the AG, the DG and the CFO will deal with. And also, I think the DG, Honorable Sengwa, wanted to know why we're not achieving our targets. I've mentioned some of those, but I'm sure you can add on that. And then the issue of hospitals which have been assessed. We do have reports, because this is done by the Office of Health Standard and Compliance. They do provide us with reports. We may not have the full report here, but we'll make those available to the members in terms of the findings of assessing of the hospitals. DL clinic status, Honorable Kaba. We do have interventions through our primary healthcare division, looking at those requirements, those standards which must be met in terms of infrastructure, in terms of human resources, in terms of IT equipments which are required for the clinics to reach the ideal clinic realization and maintenance. So those interventions, our team is supporting provinces, and we do hope that, in the next cycle, even maybe on a quarterly basis as we report, we should be able to show an improvement in terms of the missed target in as far as the 2,000 plus clinics which we wanted to reach the ideal status. The census population, yes, is providing good lessons for us. We're not at the zero baseline, but we now have updates in terms of where the people are, where the big number of population is, and also there's a lot of other information which we are going to be getting from the census, which we will be able to use for future planning as we go into the next financial year. In all our programs, we will be able to have a very good use of the census lesson. The human resource optimization as a result of the lessons. We are documenting all the lessons as a result of a decision of National Health Council, that we are far advanced in terms of putting together a document which looks at all aspects of the lessons from COVID in terms of the use of modern technology, various aspects of which we're able to adapt as a result of COVID, where instead of using people, we are able to use the technology to optimize the few human resources, including health technology. We now have, for instance, in Limpopo, a strategy on rural health, wherein they are able to acquire modern X-rays and CT scans, mammographs, and so on, and in rural district hospitals, through the use of technology. Even if you don't have a radiologist or a specialist in that area, by the use of technology, you are able to do the test, but then communicate with a specialist who's sitting somewhere, who can then be able to give instructions to the medical officers, so that even people in remote areas, the whole idea of the telemedicine usage, those are some of the experiences in as far as optimization of the experiences of COVID is concerned. Digital solutions, Of course, I think that's what members are raising here, artificial intelligence. We are learning from the experience of the pressure under COVID, and also just the development of the fourth industrial revolution. To what extent also health can benefit. So all those are being applied. The CFO will speak to issues of challenges of not meeting the 30-day payment. And already I've said that Professor Nicholas Crisp will speak to the financial implications of unused COVID vaccines. Chairperson, also you raised a number of issues, irregular expenditure also on the entities. We will be following up on that. A number of issues which I've already spoken about. We will pay attention to the challenges, of course, you've raised about the Northern Cape province. The MEC did report yesterday, even just on the stability of management. They've not had a stable HOD in a long time. They had appointed an HOD, but there are some issues which have come up. Members might have also seen in the media. The newly appointed HOD has been charged and so has been moved out of the department and probably will be on complete suspension very soon. So yeah, Chair, let me stop there and just invite. I know we're running out of time. Just invite the DG and the team, including Professor Nicholas Crisp and the CFO. DG and CFO maybe first, and then Dr. Crisp could also come in to deal with quite a number of issues which have to do with the health information systems and also vaccines. DG, can you coordinate that part?
Thank you very much, Honorable Minister, and thanks for taking most of the difficult ones. I will deal with the issue of the vaccines, and then I'm going to line up the team. On the vaccines, in total, as a department, we procured 62 million vaccines, and then we received 8.4 million vaccines on donation, mainly from the US government, which then made just above 70 million vaccines that we had as a country. Of these vaccines, we have currently destroyed 2.9 million doses of Pfizer and 16 million doses of J&J. There are others that will be destroyed in the next 5 months. And the total cost of the vaccines that will be destroyed, combined with those that were donated and those that we procured, is about 3.6 billion. But if we remove those that were donated from the actual ones that we bought, it's about 2.2 billion. We've had to destroy them because we are going to incur fruitless expenditure for storing them whilst they are no longer going to be used. That is the response that we have on the vaccines. The minister did also respond to this one yesterday during the media briefing. And then on the issue of ICT, we have taken quite a lot of steps to address the weaknesses in governance of ICT, which includes the whole issue of cybersecurity. Actually, currently, SITA is working on improving on our cybersecurity. I've personally been in contact with the new MD of SITA because that is their responsibility for government departments. We have appointed the ICT steering committee that is overseeing all the ICT issues that have been raised. So we will definitely clear all the findings on ICT as we move forward. I'm happy that the chair did actually differentiate between ICT and the digital health strategy, which Ms. Milani is going to talk about. Then the last one I want to deal with is the issue of the capacity of our internal audit unit. We have increased the capacity. We've actually approved the appointment of at least 3 senior internal auditors so that they can be able to deal with matters before the Auditor General comes. Actually, this has already assisted us that we were able to do all the investigations on the irregular expenditure. And now the matters are at consequence management within labor relations, but the CFO is going to talk about that. So I will then therefore line up the officials as follows. The CFO is going to deal with quite a lot of matters on the audit, irregular, fruitless expenditure, and all the other matters related to financial management. After him, then we will then invite Milani Volmarans, who's the head of our digital health unit, to talk about digital health and the issues that were raised by the honorable members. After Milani, I would like Ms. Gambu to just deal with the question of the learnerships. Thereafter, we will have Dr. Anban Pillay. He will deal with the matter of the blood alcohol test backlogs in Pretoria and in Johannesburg versus what is happening in Durban. So they will follow each other just like that. And then we'll have Jeanette. I know the minister has responded on the issue of IDL clinic, but I'd like Jeanette just to give a bit of more detail on the IDL clinic program. And then Mr. Morewane will touch on issues of TB and some other issues. That's how they will be lined up. I'll therefore hand over, with your indulgence, Honorable Chair, to the Chief Financial Officer. Thank you.
Thanks, DG. I will go through the questions which were referred. I think some of them I will clarify, like the issue regarding the Office of Health Standard and Compliance. Regarding the Office of Ombuds, we did have a discussions. The discussions were around funding around 10 million during the current financial year, just for the office to be able to deal with the backlogs that they're having in terms of investigations. So that process will be finalized during the adjustment process. And there were also other questions relating to underspending of the sector or the department, where there is a need for funding to provide services in the country. The most underspending that we had in the current financial year, it was relating to earmark funding, which the department was unable to shift those funding to address other commitments. That includes that 712 million for vaccines and also the 396 million for Limpopo Academic Hospital, and also even the 85 million under the capitation in the NHI. In some of the process that the minister had indicated without repeating, but the department will implement stop and reallocation to address the underspending in the provinces, so that we are able to attend to the provinces where they are having a budget pressure, while other provinces, they are having the underspendings. The other question, which was relating to the quality of financial statements or financial reports that we're having, where they also indicate the weaknesses in the leadership and others. We do indicate and that some of those adjustments, even though they were necessary to correct the previous financial statements errors, the quality of financial reports has been noted together in the national department and the provinces. So as a sector, we are strengthening the internal review of our financial reports, which it includes the audits that should be done by the internal audit, as the DG has indicated. There has been an additional internal audit staff that they have been appointed solely just to improve or to strengthen the control environment within the finances and other aspects. So the internal audit will be able to do the thorough audits in the current financial year and raise all those findings against the accounting officer. So therefore, as a department, we should be in a process to resolve all those findings, to prevent the AG to coming in and identify the same issues that have been raised by the internal audit. And we also chair having the National CFOs Forum, as the minister has indicated. So we will continue to discuss and resolve some of the sector-related issues, which includes the accounting for medical legal, which is the contingent liabilities. Currently, we have in the Eastern Cape in the qualifications, and also some of the issues outstanding in Limpopo province. We also continue to have the 10 by 10. So 10 by 10 is where we have in the 9 provinces of health sector and the 9 provinces of ages. and including the national AG and national health, where we having the engagements and we discuss to clear some of those inconsistencies that we do realize during the audit processes, and also just to appreciate, because in the previous financial year, we did have these engagements with the AG, which it has assisted the sector. With regards to the unwanted expenditures, which is unauthorized, the irregular, and the fruitless, in some of the questions, just to indicate that there were 14 cases that have been investigated by the internal audit. Those that have been finalized, they also include the ones that have been indicated by the minister. So currently, as a department, we're in a process of doing the disciplinary processes. So the matters, they have been referred to labor relations to be able to assist with the disciplinary processes. So currently, once we finalize the disciplinary processes, the department will be able to then apply for the condonement of these unwanted expenditures to the National Treasury. With regards to 359 million that has been indicated on the irregular expenditure, we would like to indicate that we agree that is true, that is 359 million that is awaiting to be condoned. Some of those that have been investigated and consequence management computed, as the minister has indicated. So while we finalize the remaining disciplinary cases, the department will proceed then to apply or request the condonement from National Treasury to be able to clear our books. Also, Chair, just to indicate, in the current financial year as the department, we did not have or we did not incur any irregular expenditure. So all those irregular expenditure in questions, they relate to all previous financial years. We also do have the unauthorized expenditure of 19.1 million as indicated. So the unauthorized expenditure was incurred in financial year 2020 and 2021. There was an investigation. Through the investigation, we also identified that there was appointment of additional staff in Program 4 that was relating to port health services during the COVID-19 pandemic. So there has been a request and documentations that we submitted to National Treasury to be able to condone the expenditure. We currently are waiting the responses from National Treasury. Also with regards to fruitless and wasteful expenditure, the one that has been indicated for 1.5 million, it's also the cases that have been incurred in the previous financial years. The year under review that we reporting to portfolio committee, there was only 49,000, which has been paid to SARS. SARS has imposed penalties to the department for late payments. But upon the investigation, we also realized that the department has made the payment in time, but then it was not transmitted in time. Hence, SARS has charged the penalty, and there was a request which we made to SARS so that we are able to reverse that irregular expenditure, that fruitless expenditure. There was also a question relating to a payment made not within 30 days. As a national department, we also want to indicate that 7,653 invoices they have been paid within 30 days, while we also had 2,736 which were not paid within 30 days. But in terms of the value, the invoices which were paid within 30 days, it's over 95%. The delays were mainly due to the invoices that we had from CCMD and also legal services for supporting the provinces. So those were a number of invoices coming from different cost centers. And hence there were delays in terms of paying some of those and including the availability of budgets. And also within the sector, just to indicate that those payments which were not made within 30 days, you'll realize that the increasing accruals, it has a direct impact to the sector in terms of compliance of paying invoices within 30 days. Because as we're having the accruals which are increasing, it means we are not being able to pay some of those invoices within the required time. So while I'm indicating the issue of accruals, so as a National Department of Health, we did manage to reduce our accruals by 39.9%, or rather, I could say from 750.9 million to 450.7 million in the previous financial year. So we do know that there is a pressure from the provinces in the increasing accruals. So the budget reduction will continue to put pressure on the critical items within the sector, which it includes our medicine accounts, like you will also realize in terms of the Eastern Cape, there was a member who also indicated the issue of unavailability of medicine and other accounts, including the lab service, the laundry services, the food and so on, which is part of the non-negotiables. Also, as the health sector, and these accruals, they've increased by 7.3%, which has increased from 16.8 billion to around 18.1 billion. So what we indicate is that the health budget reduction will continue to put the pressure to the sector, more especially in the provinces, to be able to provide the services. There has been an engagement in terms of the question on what is the department doing. There has been a couple of engagement with the National Treasury regarding the funding for the health sector. We also do indicate the service delivery impact of all those budget cuts within different components of the department. So these questions, DG, I've tried to combine all of them, and some of them, because they have been answered, I won't continue to indicate the same. Thanks, DG.
Thank you very much, CFO. Milani? Professor is back. No, thanks.
DG, thanks very much, and good afternoon to the Honourable Chairperson, Honourable Members, Minister, Deputy Minister, and to all the members and those present, including the media. My apologies, I'm in transit, so I'm in a very noisy place. So what I'll do is just do an introduction and then let Melanie deal with the details. But just to say that we have a very extensive digital development going on in preparation for NHI, but even without NHI, to be able to link the many different digital activities that are going on in the public sector across the provinces and in the private sector. Unfortunately, I think that there's not always a clear understanding of the difference between ICT, which is what happens in our own department for managing our own connectivity and the activities within the department itself, and the digital branch. So what we are doing in the NHI branch is the digital development of the digital system that will link everybody. And that includes the interoperability standards, it includes the various databases and the major elements of the components, which Melanie will take you through and explain where we are in this journey of creating that capability. It is a very long road, it's a very big undertaking, and it has been underway for some time, but we have made significant inroads in the recent past, and we have an active plan for the next 5 years. So thanks very much, DJ. With your indulgence, I will need to go to my next, to get, because I'm in transit at the moment. I will need to leave in a minute, and I'll leave you in Melani's capable hands. Thank you.
Thank you, Dr. Crisp, and good afternoon to Chairperson and members, Minister, Deputy Minister, colleagues. I'm going to just give an overview to try and respond to the questions that was asked by members. So first of all, just to indicate that digitization and digitalization requires huge investment, both in the ICT infrastructure, that includes the equipment, it includes the broadband connectivity, continuous electricity supply, etc. It also requires investment in the development of different solutions, different platforms, which we call the Health Information Exchange, where different systems and solutions need to communicate with each other in order to develop the uniform health information system for South Africa. But very important, the one area that we often not look at is the whole issue of change management. Research has shown that 70% of your effort actually need to go into the people that uses the systems. because ultimately the efficiency and the effectiveness of a solution is around the people using the system. But that's not only the healthcare workers, it's also our public to have trust in the digital solutions and to also be able to trust and access their own information. So that said, South Africa has got the Digital Health Strategy 2019 to 2024, which provide the broad strategic areas for intervention within the digital health context. It must be noted that the Digital Health Strategy was approved in 2019, and in 2020, a lot of our resources had to be redirected to develop digital solutions to support the COVID-19 interventions in the country. And therefore, there was a delay in some of the areas that was in the digital health strategy for South Africa. So at the moment, we are in the process of reviewing the digital health strategy so that it can remain relevant as the digital landscape is evolving. And it actually evolves on a daily basis. So over the time, like Dr. Crisp has mentioned, we have worked on gradually integrating the digital healthcare solution towards the achieving of one uniform health information system for South Africa, which will then contribute to the quality of healthcare. Digital health solutions, in the way that it has been evolved, could be seen as or transition into an intervention to provide health services, similar to providing medicines, etc., and therefore can improve how we render health services and also the quality of health services. So we've got different areas that we focused on. The many important, or the most important one, which has been mentioned before, is the health patient registration system. So this is specifically, if we look at the Uniform Health Information System, there's an equation that all the systems needs to talk to so that we've got one record for an individual. And we call this equation, and I'm quickly going to mention it. So it's the users of the health system have received where their services, that's the health facility or the community service point where they receive their services, and what services did they receive. And for that, we need to make sure that there's a language that the computers understand, and then also by whom did they receive these services. And that's the provider that provided the services. And then in the context of NHI, we also need to look at what cost the services is being provided. So if we look at the who received the services, the system that's been designed to define find the who and identify the who is the health patient registration system. So the health patient registration, as previously been reported, has been installed in 3,227 public health establishments. 3,138 of them is primary healthcare facilities, and 89 is hospital. We are aware that the AGSA has indicated that no training has happened with regards to the HPRS. It's just important that we note that the system has been designed to be intuitive. So if you can use the smartphone, you can use the HPRS, and it was specifically designed like this. It also accompanies the solution. When you use it, it has an extensive step-by-step manual which is embedded into the system. So we also do oversight and peer training. We've got technicians that moves from facility to facility to ensure the use and the implementation of the HPRS. And we are moving also to using digital technology. And that would be for all the solutions that will be deployed, where we will have a self-online training course for which you will then be accredited to use the different solutions. The next one, where we talk about where people are receiving services. In that context, we have developed the Master Health Facility List platform, where currently we've got 55,000 facilities and or health establishment as indicated in the National Health Act, and community service points as already being registered on that. Each one of them is being then having a unique identifier, because if you look at a computer, they work with codes. So if a facility has a unique identifier, it's easier for the system to link the different unique identifiers together in order to create an integrated record. But we sometimes find that a facility name can be spelled differently, 5 different ways. However, it would then, the computer will read it as 5 different facilities. We've also done coding. We've also further done extensive work on the enterprise architecture.
Through you, Chair. Milani, if you can just summarize.
I'm going to summarize.
Okay.
I'm almost done,
Thank you.
DG. So we've done the enterprise architecture for the digital solution, which we used with the electronic vaccination data system. And there's very few people that that believes what we are saying, but we developed a very extensive electronic vaccination data system within 3 weeks. And we go live within 3 weeks. And it's because of the preparatory work that we have done in the context of the development of the Uniform Health Information System. So also just to mention, it's the first time in the history of South Africa where a system designed by government, owned by government, funded by government, was extensively used in both the public and the private sector. So if we then look at everything that we've done, that I've just mentioned, which is just the tip of the iceberg, but I thought I'll just look at the most important ones. We're now ready to move into the electronic medical record, which is a portable record. In other words, if a person has received services in one facility, using all these linkages of different that I've just mentioned, some of them, it would be possible for a clinician in another facility to actually see what services a person has received in another facility. We will use a modular approach. It requires huge investment. We've developed a 5-year plan. The estimated plan cost for the development is going to be approximately 1.5 billion rand, and therefore we're using the modular approach. The first module of this electronic health record will be live and starting for scale up and rollout in the first quarter of the next financial year. One of the critical things that's required in order to see the efficient or get the efficiency gains in terms of quality service delivery is broadband connectivity. And we've developed a solution to work with mobile service providers, but this is funding dependent for us to implement that solution. Minister mentioned about telemedicine and how the Limpopo has capitalized on using the functionality of telemedicine. There's also using SMS mobile solutions where there's a different and other mobile solutions like the recently deployed youth chatbot where they're using AI to do that. We also are using AI and specifically machine learning in the National Department of Health big data platform called the Data Lake, which allows us to take different information systems and linking that into one record for the patient. So we as the department participated in an ethics and governance workshop on artificial intelligence in health with the WHO. And we're in the process of including a chapter on the use of artificial intelligence, but also importantly, its governance in our digital health governance framework. And this is basically what we are talking about when AI has also the NHLS is busy with the proof of concept in terms of using AI for pathology test results. And there's proven use cases that where you can use the radiology imaging also effectively in AI to improve, especially where you've got resources constraint. In terms of security, my last point, DG. So the digital health space, we've got a data center that complies with utmost security standards and security controls. We are doing regular penetration testing. We've got a partnership with the Council for Science and Industrial Research, where we're working together with the cybersecurity specialists. And one of the critical areas that we need to include further in our development is what they call a failover site. So this is where you have a duplicate site which is not on the same premises as the site where our data is being hosted. And we will look at that in the next financial year. And to date, in the past 7 years, we are hosting private information of individuals. There has been no security breaches. And we take it very serious because the most private information of an individual is your health data. Thank you, DG.
Thank you very much, Milani. Jeanette? Ms. Hunter?
Thanks, DG. I'm responding to the questions on the Ideal Clinic, and Minister did actually, as you mentioned, covered it very well. But just to say, the factors that retard the progress is the infrastructure. Many of our clinics are small. They were built many, many years ago. Infrastructure is dilapidated. And then there is the issue of human resources, and rightly the question of whether clinics have dedicated supervisors that can lead the process. And I'll speak to the question on the operational management numbers in a moment. So we and that is our focus in terms of accelerating the program. And this financial year, even though we didn't make our target, we did add significantly to the numbers we had the year before. And we are very excited with the government's initiative of blended funding, because certainly that will go a long way in eradicating that hurdle of dilapidated infrastructure. DG, if I can just look. I've got the document open. The numbers of facilities without supervision. There's 17% of primary healthcare facilities that doesn't have operational managers. Now, this is either appointed or someone with an official letter of appointment to act. Because when someone has an official letter to act, they must live up to all the responsibilities of the person of that post. And the numbers come to about 578 facilities across the country that doesn't have supervisors at the moment. Thanks, Minister and DG.
Thank you very much, Jeanette. May I quickly invite Ms. Gambu on there was a specific question on learnerships at Head Office for Youth. Ms. Gambu?
Thank you, DG. The question that was asked, I think you, DG, and also Minister had touched on the response. Mainly our targets on equity are determined by DPME, but over and above that, DPSA has issued a directive, which was issued in 2009, which says that the number of young people involved in a learnership or internship program should at least 5% of the establishment in the department. Now, unfortunately, in the past 2 years, our performance against that target has been largely influenced by fiscal constraints. And what we're going to do in the current year, we're going to engage both DPME and DPSA in light of the massive budget cuts to try and see if we can't have those targets revised. Thank you, DG.
Thank you very much. Dr. Pillay, on the blood alcohol test backlogs, just in a minute.
Thank you, DG. So I think on the blood alcohol, important to bear in mind that the forensic chemistry labs had a number of challenges in terms of service delivery. And so we had moved the forensic chemistry labs to the NHLS so that they could increase the equipment as well as improve the skills of the staff and number of staff so that they can deal with these backlogs. So the huge backlogs that are here in Gauteng are largely because Gauteng drains a much larger area. So the volume of tests that they have to do are much higher than Durban or Cape Town. And consequently, the backlogs are higher here. What the NHLS has done, and I think you may have heard that in the presentation when they were before you 2 days ago, that they are increasing the amount of equipment here in the labs in Gauteng, as well as they're moving to a new premises at the CSIR, where they will be able to have additional staff, and that would reduce the backlogs and eradicate it completely over a period of time. Thank you, DJ.
Thank you very much. The last one will be Reverend Morewane. Is going to speak on TB and a few other issues, and he's got 2 minutes. Reverend Morewane.
Yes, good afternoon, DG, and let me observe the protocol that has been established, but at least recognize the chair of the portfolio committee, the minister, the deputy minister, and other honorable members. Minister has adequately responded to the issue of TB. I just want to deal with the 2 areas of practical implementation of the TB recovery plan, which is focused on 4 key principles, which is about finding people, treating them, retaining them in care, and also advocating for prevention. So this is undergirded by 5 cardinal pillars, which are based on communication and advocacy, finding and linking people to care, treat and retain, prevent and prepare, and monitoring and assessment. So in that regard, we hope that we should be able to trace and find them. But we realize that this is linked to the number of patients that are also defaulting or have disengaged from HIV and AIDS, because we've conducted an assessment, and we're certain that by the end of the financial year, we should have been able to report very positive progress in that regard. Maybe one small thing, DG, if I have got to conclude, on the youth zones, just in particular to the question raised by the honorable member. In the Northern Cape, just as an example, we've got 671 youth zones against 161 primary healthcare facilities. So this is really a great feat, and we do hope that we will increase the numbers as we go along. And DG, I really don't want to repeat the points that the minister has raised. Let me rather pause here. Thank you very much.
Well, thank you very much, Reverend. I will hand back to my honorable minister. I'm not sure. I thought we've tried to address most of the questions. Over to you, Mhlonishwa Tau.
Thank you very much. Thank you very much, DG and the team. I wanted to invite Deputy Minister if there's areas you might want to add, but I saw the indication that this line had ceased to be alive there. Am I correct, Deputy Minister, Dr. Lomo? There was a message there that your line is disconnected. Chair, I think if not, it looks like Deputy Minister's line is off.
I've on the cell phone now.
Oh, okay.
Yes.
No, yeah, but over to you, Dinamo, if there's any particular comments you want to make on the responses so far.
Yeah. No, thank you very much, Minister, and thanks to the chairperson and all honorable members. Minister has answered very well. The part I wanted just to indicate and add on to say there has been one honorable member who was saying maybe we should do much more faster in terms of cancer interventions. Just to indicate that the foresight of the department was that 9 years ago, the department thought they should also be trying and starting the cancer prevention, especially for young girls, for cancer of the cervix. And it has gone very well. To date, we have about up to 19 years of age when these young girls are actually vaccinated in grade 9, in grade 5 at the age of 9 years, and it has been incrementally going on. So the WHO has come in to say, can we strengthen this program? It's doing very well because we are guaranteeing that maybe we will not be seeing cancer of the cervix later in life if we do this prevention. So I just thought maybe it is a very important program to indicate to the honorable members while we are dealing with the cancers right now. For those who are actually now in high schools, started 9 years ago, and we continue with the program, it is actually a very important preventative program, especially for one type of a cancer. Thank you very much, Minister. That's all I wanted to add.
Thank you very much, Chair. We don't want to take any more of the time of the members. We appreciate the opportunity. We've tried our best to respond to the matters which have been raised. Back to you. Thank you.
Thank you, Minister, Deputy Minister, DG, DDG, Chief Directors, you've all the acting DDGs. Thank you to my members. Thank you to the staff. It's been one of the best portfolio committee meetings that we've had with the National Department of Health. The discussions were so far-ranging and wide, and it touched on so many matters. It is exciting to see how this portfolio committee has really grown in its engagement with the entities and with the National Department of Health, including with the FFC and the AG. And so we hope that we'll be able to take it forward early next year on our next engagements. We look forward to all the written answers you would be forwarding, Minister and the department. And we have made a couple of recommendations. We've been very strong on a number of items. And we do hope that those we have pointed out will be given the necessary attention, not meaning that that is all that should be receiving the attention, because I think essentially the health of our people are the center of everything that we do in order for us to provide a better life for all of our people. So, Minister, that is a closing remark from you. I'm going to give you just 15 seconds, and then I'm going to close this meeting officially.
No, thanks a lot, Chair. From my side and the Deputy Minister and the team, we appreciate this opportunity. We don't take it lightly. We know that honorable members have a responsibility to represent, the electorate out there, have constituencies which they must represent. So where we may have fallen short, it's not because of lack of respect or taking the matter seriously, but we also know that there will be further engagements. And through our parliamentary licensed officers, we will communicate with your office just to consolidate the areas where we may need to make follow-ups in the written form. Thank you very much. Highly appreciated.
Thank you very much. Honorable members, that brings us to the end of our meeting. This meeting is officially adjourned. We will be attending to our BRRR or BRR report next week. Thank you very much. Have a good weekend. And go Bokke, go, and hope the Springboks do well.
Yes, thank you, Chair. Thank you, Minister.
Bye-bye.
Bye-bye.
Recording stop.
Yebo, malibongwe.
Malibongwe, siyabonga umsebenzi omuhle niwenzayo.
Malibongwe, siyabonga.
Malibongwe, Minister.
Siyabonga.
Siyabonga.
Bye-bye.